morning, everybody. It's 10 o'clock and we're going to start our meeting. For those of you who are familiar with how we used to do things pre-COVID, it would be helpful if everybody could concentrate, please. How we used to do business pre-COVID, we used to start with some feedback on board visits that we've done, and then the formal business started at 10:30, and I'm very happy to say we're back to the old way of doing it, because certainly for the board, being able to start the meeting in the hospital, meeting staff, listening to their issues, and seeing things for ourselves is an enormous plus. So I'm going to start with the group that I was in, and it included Jacqueline and Arlene, so it was a bit tricky to know who I was going to ask to do the feedback. But in the end, I decided I'd ask Jacqueline.
Thank you. So we went round gynae and maternity, so the gynae floor, the maternity pre and postnatal floor, and labour ward, and the outpatient areas, where we found, given that this is a prefabricated building, I think they do pretty well with it, regardless of that. But, you know, we were reminded when we went onto the labour ward that when it really rains, they have buckets and have to put pads down because it rains, and there's nothing else or not much else we can do with that roof there. And as well that the only lift that they have is 50 years old, not suitable for purpose. Can't get the parts for, often breaks down, and it really is a risk. So that's just the context in which they were. But we found groups of staff that really felt that they worked in good teams, that they generally enjoyed working. I think there were some issues that we talked about more or less in every area, which was around staffing and morale, and the staffing being affected by sick leave, annual leave and maternity leave. And whilst they are fully staffed in maternity, and I suspect they're one of the only units in the country that are fully staffed for maternity, they're still struggling. They were very open with us, they were very kind to us. I think Arlene, you spoke to her mum, and the women there seemed to be happy. But it's a unit that, you know, is delivering an awful lot, but there still remains some staffing challenges there. I don't know if anybody else would like to add anything to it.
Arlene?
Yep, thanks, Gillian. No, nothing to add really. I think the mum that I spoke to was very complimentary. It was her second baby, and the first one she'd had somewhere in North London, and she's having antenatal care here, and she's very, very complimentary. Quite anxious lady, which she says she's very anxious, but the midwife is so gentle with her and answers all her questions. So I think that was really positive. Staff that I spoke to felt that there were a couple of areas, in particular communication, that could be improved, and that was a midwifery support worker. And just generally speaking, they had few patients in today. So it was all calm and quiet, and then we heard a new baby cry, and everybody starting out. We all went into, but that was, so nothing else to add. And I suppose Betty, who did do the walk with me, can I just, on your behalf, or did you want to say?
I was going to introduce Betty when we started the meeting formally.
Okay, that's fine. So that's.
But since you've done it, we'd better. People will wonder who's Betty.
Yes.
So when I did the formal introductions, I was going to welcome Betty Jaguna, who is our new site chief nurse, and she came with us.
Yeah.
Which was lovely for all of us, I think, and particularly for the staff, because they got an early opportunity to meet her. So welcome. You might get another welcome in the formal part of the meeting. Nice to be welcomed twice. Right, okay, thank you for that. Now I've put my papers out of order. Thank you, Arlene. Right, that takes us on then, Phil, to your group. I don't know who's doing the feedback. Is it you?
So, yeah, I think I'll start, Gillian, if that's okay. So James, Stephen and I went to theatres and to, in fact, ITU. So we started in ITU, and it's sort of the good, the bad and the ugly, I think I described it as earlier. So if you go into the old ITU, which is where there were a number of beds, 5 beds, I think, the beds are too close together, the air conditioning is really not great at all, and the exchange of air is a problem. So you can see, and then you go to the new ITU and you see how it should be. And so there's a massive contrast between the two areas, and in between there's an area that isn't now used as ITU because the air exchange doesn't work. So we've got an area which is sort of out of use, which is interesting. What I would say, nursing staffing is good there, and they've been, I think, very successful in getting the right numbers of nurses, recruiting people. So that was good. Some agency, we had a couple of agency nurses as we went around. Both the visitors and the staff rooms are not great. They're quite small and tight. It was described to us in the heat in August. Patients were coming in and they were being put inside rooms where it was 35 degrees. So this is not an environment where you're going to recover as quickly as you would, I don't think, if you were in a proper environment. So some really difficult estates issues, I think. But what I would say, the staff all there were all it seemed to be extremely calm, organised, professional. So I thought, it's the classic, isn't it, of people doing their absolute best in circumstances they probably shouldn't be asked to work in. So that was interesting. The other comment I'd make, I'll hand over to James and Stephen, but as we walk around the hospital, there are a lot of things in the corridors, and I would say, and it's the reasoning given is always, well, there isn't enough storage space, but there is. I think, if I was a fire inspector, I would probably find some of the things that are in the corridors quite difficult, actually. And so I do think there's something needs to be thought about as to how we make sure that when things are stored in the corridors, they're in the right corridors, and there is some way of looking after that, I would suggest. So, James, do you want to, and then Stephen?
Thanks, Phil. Just a couple of things to add. I had a chat to a patient and a few of the nurses as we were walking around. I was really pleased to bump into. I did a shift as a healthcare assistant just in the recovery from COVID, and the nurse who was supervising me was on duty today, so I was really pleased to catch up with her. But she reminded me of the ongoing attention that we need to pay to the environment and the challenges that they have. And it's not only difficult for patients, but we need to remember that for our staff, when they're working in an environment that for infection control reasons we couldn't open the windows, and it was very, very hot. I think the nurses would, when beds were being allocated for responsibility, that they definitely wanted to work in the new ITU and not the old ITU environment. Just wanted to add, we then walked into theatres, and it looked very quiet because it's the start of the day and it's the emergency theatre environment. And we saw a lot of people milling around in the recovery area, and we thought this looks very inefficient. But what they were actually doing, the simulation team had come on site, and they were preparing a scenario for the recovery nurses to practice, and they were preparing a scenario with a dummy. And they were planning, they hadn't prepared anyone, so they were just telling the dummy was going to have had a heart attack whilst they were recovering from their operation, and they were going to just help train the staff in how to deal with that. And they've got a really good simulation course here where they really incorporate human factors, which is try and incorporate the trust values and civility. So I think everyone seemed really positive in that area, and it seemed a good use of time in that hour or so before the first patient comes on site.
Thank you, James. Stephen,
I mean, that's pretty comprehensive.
I thought I'd still give you the opportunity.
The only thing, talking to those doing the simulation training, I think that tension between the importance of the simulation training and the operational pressures on staff and the ability to get released to be able to undertake some of that training. Simulation team very clear that should never trump operational needs, but at the same time that tension nevertheless existed. Yeah. And then the point about the new lift and the fire evacuation and at ITU, and the fact that was awaiting sign-off was clearly an issue, because it was constructed at large expense, but it's not yet been signed off. So it seems there may be a delay in the sign-off of that.
Okay, so I mean that's a specific that needs picking up, James, doesn't it? And the point you made, Phil, about generally the place is quite cluttered, I do agree, and I have to say George's is the same, and we've acquired an awful lot more equipment, haven't we,
and
through
keep
COVID?
acquiring, yeah.
For reasons that we understand, but there isn't anywhere to put it all. And it must be difficult for patients and difficult for staff as well. So I don't have an answer on that. James, did you want to say something?
Oh, I don't have an answer on it either. I mean, one of the very live issues with some of our recent ward moves has been the balance between committing space to staff break areas, to areas where we can potentially have beds, because we've had to net reduce the number of beds in the main part of this site over a number of years because of the lack of fit environment and storage areas. Yeah. So for renal in particular with dialysis machines, it's a huge issue, and as things stand there are areas where ideally we would have beds and instead we're storing dialysis machines because they just simply can't be in the corridor. The equipment gets damaged, and also, as Phil says, it's a fire hazard. So it is a real balance. I think it is extremely helpful to just have that impression from somebody coming onto the site who hasn't been here for a while, because I think we walk around and it probably accumulates over a period of time in the same way that it does at home, and you kind of don't notice it, and then somebody new comes in who hasn't seen it for a while and says it feels quite cluttered. So I think it's really helpful feedback.
I have to say it's always striking to me that I don't want to call it clutter because I know it's essential equipment, and I think what you just did, the whole discussion's just illustrated why we need our new hospital, hasn't it? We're trying to provide outstanding care, which we largely do, but in buildings that are absolutely not fit for purpose. Right, so that takes us on to Derek and Anne. It says here, Derek, Anne, and Richard went off to renal. Is that correct?
Yes, and I said
Derek, are you going to start?
I said I'd kick off, and Richard and Anne will chip in, I hope. Yes, we went to renal unit, which is spread over several sites within the campus, but we spent most of our time in Richard Bright ward, which is one of the older buildings, and then went up to B6, which is where some of the renal wards have been relocated to. I think first of all, say we were around with Teresa and Sharon, and I think we met Miriam, who's the head of the day unit, very briefly. And I was impressed by the sense of respect for one another and respect for the staff. There was good body language, good sort of rapport, and a sense of control and knowledge of. I was assured there was good grip on what was going on. They knew what was going on. They knew what the issues were, and I think that was very impressive, and they were very helpful. So I felt confident that in terms of the nursing, the medical staff, there was good leadership and good control. That sense came over. One of the key things that came over to, particularly to Ginny Kwan, one of the renal physicians, was how many patients are what you might call stuck in a bed waiting for social services. And you do the random sampling of hello to a patient, and I chatted to a man from Mitcham who's been in a bed for 6 months, and he's waiting for housing. And I'm oversimplifying, hugely, but basically he said, I'm just waiting for them to get the housing sorted out because I can't go back to the place I was in before. And how long have you been in hospital? 6 months now. And I got the impression that wasn't unusual. And I think just the limited facilities for patients with it. It's a very tight ward. It's a big single bay. You basically have about 12, 15 beds. He sits by his bedside all day, has done for 6 months. He's got a TV on one side, but there's nothing going on. There's no, I don't know whether he has visitors, but there's, obviously the WRMPS type, the trolleys are all stopped because of COVID. And I did feel a bit sort of, what's his quality of life? There's no day room. And he has his meals by his bedside. He watches television by his bedside. He's just stuck there for 6 months waiting for rehousing. So I thought that was very sad. I mean, and it's a system problem. The other thing, of course, that came over was the poor estate. There's no air conditioning that I could see in Richard Bright. The air handling is, there's a door open, that kind of helps. You feel as if everything's been sort of stuck to the wall with, things have been repiped or rechanneled, and, just... it's a very noisy environment because the beepers are going off a lot of the time. So it's not a comfortable environment to work in. The corridor is very cluttered, and I did go to Richard Bright 3 years ago, and we commented then on the corridor being very cluttered, but there is no storage space. You see, the linen cupboard is the trolley in the corridor, because there is no linen cupboard. So the constraints under which staff are working is very difficult. There was a staff room, which was nice. I wanted to think about how they were looking after the well-being of staff. It's quite pokey, and they lost their meeting room to the Cerner team, which I think was a bit of a blow. But the Cerner team have to be somewhere, I guess. But there was a sense in which, well, we used to have this nice big meeting room, but now we've been put in this little room because that's all there is. So again, it comes back to estates. We want to be a cracked record, but the estates is clearly an issue. Then we went up to B6, and there you've got 4-bedded bays, which make it very hard to keep an eye on your patients. With dialysis machines, you can only get 3 patients in a 4-bedded bay. And if you put 4 patients in, then you've got beds really close together. So, sorry, estates again. It's a really difficult work environment, and I think reconfiguring the staffing, moving from one footprint to another, has been quite difficult. So, trying to get the staffing numbers right for working in a different environment has been quite a challenge. But again, I got the impression that they had a plan and were working through it, and you know, no one was throwing up their hands and saying in the air and saying we can't do this, but it was a challenge. I'll stop there. Richard, Anne, do you think that's fair?
Well, shall we hear from Anne first? Do you mind, Richard?
Perfectly fair. And it was actually very helpful to see all the different bits. We didn't go to the unit at the front of the hospital, but actually seeing all of the different bits in one visit actually was quite helpful. I guess there would only be 2 things that I would add. One was, I understand why it's happened, but we went to see the ward that we've just invested in and, you know, brought up to sort of modern standards, and it's still too pokey. Now, you know, as Richard said, you can't do much with the walls, but it just makes you realise that even new wards are a stopgap, aren't they? Because you could lie in bed in one of their units and hold hands with the patient in the next bed if you were so minded. The other thing I would say, and just because it was quite interesting to reflect, was that the staff that were showing us around raised the group in a very positive light without being prompted. Really, I say no more.
Thank you, Anne. Richard, anything to add?
Just a couple of things. I very much echo what Derek was saying about how morale feels or how people treat each other. So not just on this walkabout, but whenever I've been to the renal department before, it's very striking to me how warm and positive people are towards each other. And you get a sense of a really good team, and I get that sense. I spoke to Franklin, who's the lead phlebotomist for the trust, and he was talking about phlebotomy in a very positive way, and the nurses were saying how good the phlebotomy is. And these are people who don't normally get a shout out, so I thought it was worth mentioning that. Just in terms of rate limiting steps, so Ginny Kwan, the clinical director who was working clinically there, said the 2 biggest things that they have that are issues at the estates, which we've covered, and getting patients out. And homelessness is something which accounts probably for a substantial number of bed days that are not well spent. And I just wonder if there's any more that we can do around homelessness. One of the big challenges is a lot of these people come from areas outside the immediate catchment area. That's one of the, so I'm sure this is hard, but I just wonder if there's more that we can do. And just the only other thing I wanted to pick out was that when we went to B6, they told us that although they thought that all their windows were properly restricted, they then realised that some work had gone on which had unrestricted a window. So the point is an unrestricted window you can jump out of. And they were, I thought it was very commendable and very positive that they told us about that quite spontaneously and openly. And they fixed the problem, it's sorted. I wanted to raise it partly because I've worked in a trust where somebody did jump out of a window and died, and you never forget that. It might be worth just checking that our processes and procedures don't allow us to trip up like that.
Thank you, Richard, for those points. I know I've seen James making careful notes. On the housing point, housing is a district council responsibility, not a county council responsibility, which makes it more difficult because it means you're dealing with umpteen different local authorities. If a lot of the patients are Surrey, there will be a forum that we ought to be able to access. And it may be that a letter from James and Jacqueline, and possibly, you know, from the board as well, could just get a bit of traction on this, because it's unacceptable that people are left, leaving aside that they're taking a bed that others could use. That is no quality of life for somebody, however kind we are to them, stuck on a ward for 6 months, is it? It's an awful situation. James, you wanted to come in?
Yeah, I mean, just probably two things on renal. I mean, the first is that hopefully it did come through that the plan is to be out of Richard Bright for renal patients. So the plan is to get into a 6, and quite a lot of the work that we've been doing at the moment is basically to work out how we get the right mix, the most appropriate mix of patients for the available estate that we've got. So we've got B1 ward, which is a set of side rooms, which we need to use for medical patients, but it's which medical patients you use for an all side room ward. It's how you get the medical patients out of A6 but use B1, and then it's also about getting the hem-onc patients who've been on B1 up into C6. So there's a very involved ward restack process which we're in the late stages of concluding, and some of our operational pressures this week have been about decanting B1 so that we can do the refurb work that's needed on B1. I think your point about the distribution with the housing issues is entirely right. So I think when we did the engagement on the renal move, we thought we were dealing with something like 17 districts and boroughs, because it actually extends out into Berkshire and Hampshire as well. But I do think that if there is an opportunity to flag perhaps with some specifics some of the housing issues that we're having, if they are in Surrey, or perhaps if they are in Merton for the Mitcham gentleman, then we could do that. I think the thing that it gets missed with renal patients is that they are often very psychosocially complex, as well as having renal issues as well. And, you know, so therefore, in a sense, it's the one service for which Epsom and St Helier encounters many of the issues that St George's encounters with their tertiary patients when they're discharging them directly, which is a very, very large range of authorities that need to be dealt with in order to get them moved.
Thank you, James. Right, so the next group is Aruna and James's own, but I think that's you, Aruna. Yeah?
We'll do it. So we were taken to 4 outpatient areas.
Sorry, I'm just told there might be a fire alarm.
Yeah, fire alarm's going to go off. It's a test, apparently.
It's a test,
yes.
So we will carry on.
Yeah.
Thank you very much. Sorry, Aruna. I was aware that there was something I needed to be told. I wasn't quite, but that's it. So we mustn't panic. We must just carry on. So you do that.
So we were taken to we did outpatients. We were taken to 4 outpatient areas. Thank you, Derek. I forgot about the mic. We were shown around by Suzanne, who is a clinical matron. I should hasten to add 32 years in the trust. Absolutely loves it here. So there's an ingredient here that really, really works, and we need to hold on to that. And Emma, who is an Associate Director of Planned Care, and she joined us 18 months ago, and from a very large trust. Sorry, let's turn this thing off. Yes, from a very large trust, and has already been promoted in our environment. So I thought that was important to register, because that says there is something here that really works, and we need to hold on to that. So yes, we were shown 4 different outpatient areas, covering a variety of specialities. There was one particular one which was kind of the fracture clinic. Walked around dermatology, dedicated dermatology and rheumatology area. Not my day today.
I don't know how long it goes on for.
Is that it?
No, there might be another one.
Should I carry
Give it a go.
Give it a go.
Give it a
All
go.
right. Again, I mean, I think my overwhelming feeling in terms of people and culture was every room we opened, I was really welcome, and the people that took me were really welcome, and you could see the body language and the dynamic. It did make me scratch my head and think, our staff survey, who is responding to this? Because I don't see that when I walked. So it's been really great to be able to walk the floors. My overwhelming feeling, again, if I were a patient, is that it was quiet. We hadn't started yet. It was 10 to 9 when we started, so it was quiet. It was clean. It was very pleasant. There was an area, like a kitchenette area, where people were, could be offered a drink, water, etc. So I thought that was really great. What could we improve? Signage. I mean, if I were a patient and there's 4 different outpatient areas, I wouldn't know where to go. And it was described to me that somebody did turn up, forgot their letter, and was completely confused, because you could be a particular specialty, but it could be in any of those 4 outpatient areas. So where would you be seen? So that could be improved. Corridors, again, this is going back to estates. Trying to get wheelchairs around corridors, really difficult. The X-ray department, quite far away from the fracture clinic. Again, that's down to our estates. We're doing the best we can. But here's one thing that I think we could do something about, which is the IT. So I asked them, if there was one thing I needed to take to board that would make your life easier, and they said IT. And so, and what they mean by IT is consultant sees patient, needs to print off blood report. There's no connectivity. Consultant needs to order X-ray, no connectivity. And so you're kind of slightly stuck, and that's very inefficient. So I shared that with James. I think, that's it in a nutshell. James, do you want to add something?
I was only with you for the first part of the visit. I think that the fact that the reception for a fracture clinic is actually not in the fracture clinic, but is over the corridor, is just sort of indicative of the fact that we are continuing to, put quartz in pint pots, really, in terms of some of the areas. I think the reflection on the IT is helpful, and I think it's something perhaps for Andrew and I to discuss, because it made me reflect that we don't actually report system uptime anywhere within our metrics at the moment. So when all of our systems have downtime, we notice, because we go into a business continuity incident, but there may be smaller areas of downtime that don't hit that trigger, and that maybe we're not actually visible on the overall impact that's having. So that is certainly something, when we're looking at our governance, we can have a look at.
Yeah, I think they're really good points. In the signage one, I think it's true of all hospitals. I think the signage is decent here. I've always thought that. But it can always be improved, I guess. So, right, we're running short of time, and Andrew, where are you, Andrew? Oh, yeah. It's always difficult when you're in this line of sight. You accompanied Parveen Kumar, who's actually a George's Ned, but because we're working closely together, we invite the Neds from the other trust if they would like to join us. And Parveen kindly took up the invitation. And you and she went to paediatrics.
And she did a runner before the feedback.
Well, we couldn't properly have expected her to feedback, could we, Andrew?
I know. So, for the sake of time, I think it's the key issues that you've heard in most of the other areas. So certainly, the constraints of the estate, the building, while certain bits have been done up, i.e. the ward has been recently refurbed, which superficially looks very nice and it's very pleasant to walk around. It's very small. The areas are very small. So there's 4-bedded bays where, query, you probably shouldn't really have 4 beds in them. The lift, they've had to buy special beds to fit in the lift. So you can't use the generic hospital beds within that area. So there are real constraints in the nature of the estate, which, I could repeat many others, but most of it we've heard before through the other feedback here. Activity pressures, certainly, in paediatric ED, they're seeing a lot more patients coming through. Attributed largely, to the COVID and the backlog coming back. And while they've been in the summer lull, they haven't necessarily felt it's been that much of a lull. and they're not particularly looking forward to moving into autumn, kids going back to school, etc., etc. So, and that wasn't just nursing staff, that was the medical staff of feeding that back as well. Staffing raised as an issue, I think largely about recruitment, the ability to find staff. It's quoted as being it's not just a Epsom-Elliott problem, it's a wider system problem in paediatrics to be able to find sufficient staff to attract. There just aren't enough being trained, and that market is constrained. Saying that, the staff were very positive. They accepted and recognised the challenges and the environments they had, and they were very accepting. You can't just make this perfect overnight. But they wanted to see that continual upgrade and update and that engagement in those issues, and certainly we're looking forward to the SETCH in terms of that ability, and then the service moving into a new service, a new physical location, which would solve a lot of those problems and challenges. And just for good measure, because no one else has mentioned it, car parking came up. No, but just particularly around access in terms of for on-call staff and people coming on duty, at the beginning. How do we potentially prioritise that? So some community staff being able to access parking here as well, in a way that they are potentially able to do on other sites. But also recognising the pressures that everybody has exceptions as well. But those were the main issues.
Can I just add one about recruitment?
Yeah, can I just thank Andrew?
You can.
Thank you, Andrew, and then you add what you wanted to add about recruitment, Jacqueline.
So actually that recruitment came up actually when we went around maternity. I forgot to mention that.
Yeah.
And I think, Saskia, I don't know whether you've got the details from the hub when we go through the HR bit of the IQPR, but I think just understanding that, because their experience is 12 weeks, and that's not the experience I'm being given to give, that's what the hub is doing. So I think just unpicking some of that about reality versus what we're being told, either way, that is.
12 weeks from out to start.
Yeah. So if we can pick that up when we do about the HR
Yes,
metrics,
I think that would be very helpful. I mean, there was a lot of passion behind it, because these are people whose workload is increasing because the patients, there's just more and more patients. It's very striking yesterday as well that it's not only more patients, but the acuity is so much worse, and often young patients actually, not just elderly patients, and so staff are running harder and harder to keep going, and long staffing gaps just make their lives harder. But I think that the kind of common theme for everything we've heard is just the heroic job that our staff do. They just keep going. They provide great care, and they do it in buildings that are not fit for purpose. So we need to keep up all our efforts in relation to the SETCH. So I'm going to morph kind of seamlessly into our formal meeting now. So, well,
sorry,
Peter.
Gillian, I couldn't join the session this morning, but I did visit.
You did, yes.
And Epsom last week. I'll keep it brief.
Yes, if you would. Thank you, Peter. Sorry, you weren't on my list, so.
No, I appreciate that. So, just briefly, I mean, I was escorted by Martha and Nikki, who were brilliant at showing the full range from outpatients here to maternity over at Epsom. I mean, in one sense, they're clearly worlds apart in terms of their catchment, but and on the estate front, that certainly is true. But in other ways, a lot of commonalities, and the three positives that just to briefly reference is, again, the professionalism and commitment of the staff was universally present across both sites and whichever ward I visited. Secondly, the very positive patient feedback, and they were delighted to be engaged, but when we spoke to them, they confirmed great service and were happy. Now, whether they should be more demanding is a question, but nonetheless that was positive. And thirdly, encountered one of the volunteers and enjoyed the Friends of St Helier Cap at lunchtime. So just underlining, they probably wouldn't normally get a visit, but the important role that volunteers play in supporting the hospital. And in a similar vein, also stopped off at one of the storerooms and talked to one of the store managers, who was so proud of the fact that the room was perfect and was there to support the medical team around them. But just underlining the fact it is a team, and if you've got bad supply and you can't access them, then things don't run as smoothly. So that was a nice way of rounding off. The two things that struck me, though, it echoes some of the earlier comments, one about the staffing and vacancy position. We know nationally 130,000, 1 in 10 vacancies, so it's a huge national problem. But people are getting by, but it's a lot of strain, stress, and the worry is more when we come to winter, sustaining that, and the complete dependency on overseas recruitment for nursing staff, and how in the longer term how sustainable is that. I think there were very positive comments about those staff, but nonetheless. And the second was about the delayed discharges again. And in one of the wards, they were commemorating, if you like, the 100th day of the person being in that ward who could have been released probably after day 2 or 3. And there were others in 20s and 30 days, likewise, who could have been. So it just underlines that huge problem that we've touched on. But, you know, just leaving it as it's just undermines so much of the rest of the good work going on, so it's clearly a priority. That'll do for now, thank you.
Thank you, Peter. That's really helpful. Thank you for adding those comments from your visit earlier. Well, it was last week actually now, wasn't it? Thank you very much indeed. So now I'll morph seamlessly, but actually with a very large theme, into the formal meeting. So formal welcome to everybody, particularly Betty, our new site nurse, and members of the public who are with us. We have apologies today from Martin Kirk, who's on holiday. Chris Elliott will be late. He's had some urgent family business to attend to, but will be joining us as soon as he's able to. And apologies from Paul de Gama, who is on holiday and is represented by Saskia. Let's move on then to declarations of interest. The usual, unless there's anything new? No? Yeah. Don't need to go through all of those, do we, Stephen? No. Minutes of the previous board meeting. Are people happy to accept those as a true record? Yep, lovely, thank you. And the action log and matters arising. So there are 3 items on our action log. And the first one was about the return to work policy that we heard about at our last board meeting, when we had a staff who was also patient story actually. And I was talking to a member of staff here who didn't know anything about the new return to work policy. So I think, Saskia, it would be helpful if you could give us an oral update on progress.
Yes, thank you, Gillian. So the phased return to work policy following sickness absence as it currently stands is that for the hours that people are not able to work, because they will come back part-time to start off with and build up in a phased way, is that they need to take annual leave or they will be unpaid for those hours. So the proposal is that they will receive full pay for the hours in their entirety, so they won't be required to take annual leave or receive nil pay going forward. Now the phased return is for a period of between 2 to 4 weeks, and by exception it goes over 4 weeks, and that is in line with the approach that's taken the policy at St George's. So the outcome will be, and apologies I wasn't at the previous meeting, will be that Epsom St Helier will follow suit and do the same thing from this month after going through the right governance and making those changes properly.
So that's from September?
Yes.
Yeah, because we were told in July that it was about to happen. So
yes.
It's taken a couple of months.
Yes.
Which will have had an adverse impact on some staff actually, and probably the member of staff who was talking to us. So, but we're absolutely clear, are we, Saskia? As from yesterday, this is now trust policy.
We are.
Okay, good. And it will be communicated?
Yes.
Lovely. Thank you very much indeed. The next item is about finance section of the terms of reference. Is that's done, so we don't need to worry about that. And the final one is not yet due, so I don't think we need to talk about that either, do we? No. Okay, lovely, thank you. Unless there's any other points that people want to raise on the action log, we'll move on to item 1.5, the Chief Executive's update. Jacqueline.
Thank you very much, Chairman. So over the last couple of months since the board last met, I think we all know we've had quite adverse weather in terms of heat waves, and that's also given us operational challenges, I think, which we've probably discussed as part of the feedback from the wards, and it has been really tough for staff and patients alike. We've also had, I think it was on the Epsom site, a couple of IT outages which I have to say were tackled effectively and efficiently, and I know that when I spoke to Ruth after the second one that we were going to do an after action review or after a review of what had happened, because twice in a couple of weeks actually feels like there must be something there. So I know that Ruth is going to lead off on that. So hopefully we'll get a bit of feedback back around that. But of course, as it begins to turn a bit more autumnal and the nights are beginning to draw in, it reminds us we're heading off into winter. And of course, that means that we need to start preparing for that. And we will bring back to the board our winter resilience plans in November. That's the next meeting, isn't it? Yes, November. So they will come back then, and we're already beginning to plan all of that. That's already in plan. And not only that, but we will also be launching a full flu and COVID campaign with ensuring we've got capacity in order to make sure that we vaccinate our staff. And lastly, in terms of this bit, we know that our staff are also facing strains of cost of living. And we've done one thing, which is we've made sure our community nurses aren't disadvantaged by the hike in petrol. And that was just a 3 month, I think it was 3 months, wasn't it, Thursday, that we gave additional travelling expenses to them, which hopefully will have helped. But we've also been looking at what else we can do, particularly around making sure that we are clear about where staff can go. We also get discounts as NHS staff, so making sure staff are absolutely clear about that. And also other things that, like, we know that there's an awful lot out in the public domain around how you can reduce heating costs, etc., which I suspect is going to be the biggest issue, and how we can get that in the right format for staff to be able to access. And we'll be thinking about more things that we need to do with our charities as well. I've also put there the NHS Business Plan, which we will work through, and I don't know whether this is just for this year or whether it's for the ongoing years.
The list on there, sorry Jacqueline, relate to the NHS priorities for 22-23.
Yeah, and as we know that come 23-24 we will be launching our own strategy. And we'll incorporate appropriately what we need to in terms of national priorities going forward as well as our own. We continue to focus on our Build Your Own Hospital. And of course, as we've said today, I think we've highlighted beautifully the challenges that we have, particularly on this site. And I'll talk a bit more about that in our part 2. And just in terms of the autumn vaccine plans, just to be clear about who will be offering COVID vaccines to, so residents in care homes and staff in care homes, frontline health and social care workers, all 65-year plus, and adults aged 16 to 64 in clinically high-risk groups. In regards to our operational details, I know James will go through that in some detail when we get to that bit of the agenda. But it's quite pleasing to see that we've hit our targets for our non-elective activity over the past few weeks. And I know that theatre utilisation, and we have a theatre utilisation group now set up, looking at how we can actually get more through our theatres, because we know that that's important both for patients and financially. In terms of the APC, David Williams, we've appointed as the new director. He comes from Buckinghamshire Healthcare, where he was the Director of Strategy. And just a few parish notices, if you'd like, appointments and awards. So I know you'll want to congratulate two of our well-deserved teams. The first is for Epsom and St Helier Maternity Cultural Transformation Group. And I think we know they've already won one award, and they've also been shortlisted for a second HSJ award. And I know they do some great work in this area, really outstanding work. And also, well done to John Needham. I'm sure many of us know John. He's a star. And he's been shortlisted for the BBC Make a Difference Award. And as you know, John was responsible for setting up Letters for Loved Ones as part of a response to COVID. And I think many other people copied what was done here. The last bit that isn't in the report, so just to formally acknowledge that we had a visit from Boris Johnson, our Prime Minister, last Friday, who visited Swelliok. It was all part of announcing the 1.5 billion for 50 new surgical hubs. And of course we know Swelliok is the first and the best exemplar of a hub. So I think it was a really good visit. The staff really enjoyed it. I think he really enjoyed it as well.
He did.
And I know that we also had opportunity to talk to him a little bit about BYFH. So with that, Gillian, I'll leave it there and I'll take any questions.
Thank you very much indeed, Jacqueline. So any questions? Peter?
Thanks, Jacqueline. Just picking up the COVID booster campaign, as it were, for the autumn. Do you anticipate a challenge in getting both staff and others through? Because there's a general sense that that's yesterday's news and we've moved on. And how do you think we're going to reinforce the message? It's going to be really important that people do this.
Well, I might throw that over to Arlene because she's leading it, and I think we're taking best practice from both organisations to drive up vaccination rates. So if that's all right, may I pass to Arlene?
Of course.
Thanks, Jacqueline. Yes, as Jacqueline says, what we're doing is that we're pulling together the best bits from George's and Epsom and St Helier, and we have a steering group that does include comms. So we plan to start the communications now, and we're doing it alongside our flu campaign as well, so that we're capturing all of it at the same time. So comms will start going out very soon, and then we have HR involved, and so that we're capturing the data. But no doubt, as you say, there might be some kind of, COVID is old news, but we will wrap it in with flu, which isn't old news and which we keep having to do anyway. So I think good comms is going to be key.
I think one of the bits from St George's was always about educating staff. A lot of time educating staff actually has helped. And one of the things that we do know is that we always look towards Australia for what sort of flu season they had, and they've had a pretty terrible one. So, and that's out in the public domain. So that for me is a real driver about how we can encourage more of our staff to have the flu jab. And I had flu and ended up in hospital and nearly died a couple of years ago. So I think there is. For me, it's a real passion about making sure that we, over 25,000 people a year die of flu. So that's really important.
Gillian, if I may just come back, that's really good. There is a wider worry as well about resistance to vaccinations with the re-emergence of polio, and whether other MMRs, if that's all right, whether, again, take-up might, if there's a general kind of anti-vax vein cutting through some of that. So it's going to be quite challenging across the piece, I suspect.
Well, there's a whole cohort of us who can't wait to have our next vaccination. It is extraordinary, isn't it? There does seem to be these people who are, let me get as close to it as I possibly can be, and others who, very relaxed. So a good point, Peter. Right, if can't see anyone else. So if we could note Jacqueline's report and move on to part 2 of the agenda. And we're going to start with Audit Committee. So, Peter, that's you.
Yeah, thank you. And we had a good meeting and a few highlights. The summary covers the essential points, but overall, really good progress on audit recommendations. No outstanding recommendations, which is excellent. That's a rare thing to happen. We took a couple of moderate assurance reports around the patient experience and medicine management, which were generally fine, but some areas for further work going forward. We took a report on a piece of work that's going to be done over the next few months over financial sustainability assessment, and this is a requirement placed on us by, I think, NHS England, and I'm sure Andrew can fill in the gaps, as it were, but this is to provide assurance that we've got robust finance systems and controls in place. And I think we're confident, looking at Andrew, that will be the case in terms of what emerges as the output. But it will really help, I think, to provide assurance locally and nationally that we do have a good grip on those issues when we're thinking about budget issues, and we'll hear more about the budget challenge later on. But to know that we are looking at efficiencies, we are watching the pennies, and we're doing things properly is really helpful assurance. So that's why that's particularly important. Good work going on, as always, on counter fraud and cyber. And I think there's a brief reference to the internal audit going out to tender. And there has been a slight delay on that, but we are looking to expedite that imminently to ensure that we've got a good contract in place for the coming year. But otherwise, that was the essential highlights, Gillian. Thank you.
Thank you very much indeed, Peter. Any questions to Peter? No? Okay, so we've got a number of things to do actually in relation to this report. We need to note it, but we also need to approve the updated terms of reference for the committee and note the forward work programmes. Everyone happy to do that? Lovely, thank you very much. So that takes us on to the Estates Assurance Committee. Anne.
Thank you, Gillian. So I think this was the fourth meeting. We agreed that we, given this state of the estate a few months ago, that we actually needed to set up a separate Estates Assurance Committee. And I think after the inaugural meeting, we agreed that we would have a series of deep dives, the first of which were on water and then on ventilation. And this time we were looking at fire. So I won't go through everything that's in the paper, but we went through the legal requirements that cover fire for a building such as ours. We looked at how it was governed within the trust, and how we actually monitor our compliance with the various standards. And I don't think anything in that raised concerns with members of the committee. So we were satisfied that we'd got a grip, albeit, as we've already said today, the buildings are not in a great state, and we don't have an awful lot of money. So whilst we've prioritised money on backlog maintenance to deal with the many risks that we carry, we cannot address everything that we need to address, but we are doing that. So I think the committee understood where we were. It isn't a comfortable place, but felt that the systems and the processes were in place to make sure that we remain safe. Previously, people have raised the issue of how are green and sustainable issues dealt with in building processes, and we did take a paper that looked at that. It's clearly a difficult one because we would always want to invest in things that gave us the most sustainable options, but they may not also be affordable. So getting that balance right is quite tricky. But we were assured that we were complying with all the NHS regulations around that. And then finally, we obviously we're very closely related to the Build Your Future Hospital project board, and we are very cognizant of the continued delay in that programme, now not expected to be before 2027 and maybe a bit after that. And that of course brings into stark focus the state of the buildings that we're in today and that we've all been to visit, some of which might have lasted if the sector had been built when it was originally planned, now don't look like they will. And that will require us over the next year or so, I guess, to think differently about what we're going to do whilst the new hospital is delayed. Shall I leave it there?
Thank you, Anne. Any questions for Anne? Richard?
I just wanted to raise a point about fire safety, because I think the big picture that Anne's described is very positive. I have worked in organisations in which every department has a number of members of staff who are allocated the role of a sort of fire marshal, fire supervisor, to make sure the environment is as fire safe as possible. In my walkabouts, when I ask people about that, it's not in general something that people recognise. And I wonder if there's some work we can do around that. Distributing responsibility for fire safety more among the staff, because I think we think about it very carefully on board. I think we pay a lot of attention to it, but I'm not sure how much we distribute the consciousness about how important it is.
That's a good point. I suspect Anne doesn't know the answer. James, can you say anything well, can you elaborate at all on that?
Nothing immediately helpful, but it can go on my list to discuss with Trevor later.
Thank you, James. Sorry, I'm
Gillian,
sure
perhaps
that
if I can comment.
Oh, James, yes.
So if you see, the theory is that it is distributed as you describe, Richard, and members of staff who wear a red lanyard saying fire marshals. So each department should, in theory, have a fire marshal, but it sounds like in practice it's not recognised, and there may be some work to do to make sure that people understand who they are and what roles they have.
It needs constant nurturing, this kind of thing, doesn't it? And also it doesn't relate to ESTH. There was a fire alarm at George's last week, I think, when I was there. And actually quite a lot of staff were not respectful of the wardens. So that's another issue as well, about taking notice and doing as they're told. You know, none of us want to leave when we're in the middle of something. Stephen and I were directly involved, but I just find it unacceptable that staff are rude to each other when they're just trying to do the right thing. So, you wanted to come back, Richard?
Just to volunteer to help. I think I wouldn't want to feel like we're handing it all over to James. I think that having an effective fire marshal system requires everybody to promote this within their own professional groups and staff groups. So I'm volunteering to do that with the doctors.
That's very helpful. Thank you, Richard. And I'm sure it'll prompt others to. They may not pipe up now, but I'm sure they'll think that they can help as well. Right, so that takes us on to the finance. So we note the estates assurance and the points that we've just discussed about fire marshals. And then finance committee in common is you again.
It is indeed. So we've met twice since the last board meeting in July and in August. And we always have standing items around the sort of in-year performance. At the moment, we are still on the planning for the current year, which is not a comfortable place to be. In most organisations, one would have expected to have done that before the start of the year and to now be in monitoring against the plan. But we will come back to that. And obviously, we also talk about operational performance, which we have elsewhere on the agenda as well. We've now added, because it was something that hadn't previously had a home in a board subcommittee, a keener focus on IT risks. Interesting, given the comments that were raised. And then we deal with other items on a sort of an ad hoc basis. So in terms of the financial position, we're not quite on plan in this trust. Some of that is because of the treatment of the elective recovery fund money, where we've been asked to deal with it in a particular way by the system. Some of it, and I think this is one where we will need to have a keen focus through the Finance Committee, is because we're a little bit behind on the cost improvement programmes. And given the challenge of the cost improvement programmes and the ramp up towards the end of the year, that's something that we really can't afford to get too behind on. So we will need to look at that very carefully. The other thing that we are monitoring very carefully now in the committee is cash. When in normal years the cash sort of follows the basic income within the budget, but if actually you've got to generate quite a lot of cost improvement savings, then you need to do that in a recurrent way if you're going to deliver a cash saving. So we need to make sure, I'm sure Andrew will say he's not worried that we will run out of cash, and I don't think we will. It's that we have to monitor it very carefully. I won't say much on the operational performance because we will talk about that later, but what I would say is I think the committee felt broadly assured that in awe of the work that the staff were doing in the circumstances, and actually felt that they were doing incredibly well, albeit not always meeting the national standards. But I don't think we're certainly not alone in that. And actually, there are some aspects of the performance here which are really good, and so we didn't have any concerns that we wanted to raise on that. The only other thing I would highlight, and this came out of a discussion around the IT risk that we looked at, was we were considering actually in relation to the hot weather, the impact that has. Clearly it has impacts on our patients and our staff. It also has impacts on our servers, and they can really overheat in the kind of hot weather. And we'd had some issues with that I don't think we probably need to have, if we had the money, more resilience in the way that we manage our servers. Sadly, we don't have enough capital money to do everything, but it was an area of vulnerability that we were focused on, and we'll come back to. Shall I leave it there?
Thank you, Anne. I actually did a visit to medical records in Epsom and saw the cables and things they'd had to put in to support the server room. It was extraordinary, and it can't be cost effective really. It must be a very expensive solution. So more of the same really.
Renting your service is not good either.
Exactly. Anyway, thank you for that report. Aruna.
So, and I'm really pleased to hear that your committee is looking at IT risks. The question I have is, we look at cyber metrics in the audit committee, but we're looking at IT risk in the finance committee. What's the plan to bring it together? Because cyber is very much an IT risk. So I'm just concerned that it's in two separate committees. I mean, maybe it's something we take away and think about, Stephen, in terms of where does it belong? Because it is a holistic thing, really.
The question is it done twice badly or twice well or inadequately with things falling between the gap? I don't know the answer, and Anne may not either.
I think it's not uncommon for cybersecurity to be dealt with both at an audit committee and at a finance committee, so I don't think we're out of step. And my view is we're probably not yet doing it well enough in either. I mean, Peter can speak for the audit committee, so I think there's probably work to do, and it's probably something for Peter and I to work on to make sure that we do it once and we do it well enough. But I think more work to do.
I thank you for that. I mean, I think we'd really need to be focused on IT, both from an availability but also from a cyber. I mean, organizations I work with are really, really struggling with the latter and completely crippled. I mean, even within it's public knowledge, even care notes can't get it up and running anymore in mental health still. Can't get any performance metrics. So I just want to make us aware of the acuteness of IT issues, not just in care notes and the NHS, but across all sectors.
I think we understand it intellectually, don't we? But you're reminding us that we have to make sure there's an awful lot of practice behind it. Andrew, did you want to say anything about our cybersecurity work?
To follow on sort of Anne's comments, I think it is work in progress. There is a lot of focus on this, which is not just internal within the trust, it's external as well. So the DSPT, the cyber toolkit that we're all required to complete and fill in, is a major point of focus. And again, that piece of work is rooted very specifically through the audit committee because we are asked to do it that way, and that's one of the reasons cyber is discussed at audit.
Yeah.
I think what I would suggest we need to do is understand what are the specific things that need to go through audit for those purposes, but then we take the wider review of IT through finance committee. That's what we do largely at George's. So we take a more holistic view through finance, and we deal with specific issues as required at the audit committee. Well, obviously any bigger material risks, but we are looking to draw that out, and we did have, as you say, the first time we had a more detailed paper on that wider risk environment on IT, which we'll now seek to flesh out to make sure there's real clarity in terms of understanding those issues.
I think that's helpful, Andrew, and thank you for raising it, Aruna. Any other points? Peter?
Thank you, and I agree with what Anne said, and we'll continue to work closely to make sure we don't duplicate. My question was just more around the impact of the energy price increases on the trust and its budget, because it's likely to be significant, whether it's summer and aircon or winter and heating. And I understand there's an assurance about covering off those costs, but I would like to be assured that that covers all eventualities. When that assurance was given, did it anticipate doubling or tripling of prices? And actually, we're not covered by the cap, as I understand it. So it is all down to whatever assurance we may be given. So just a bit more on where we stand in relation to energy price would be helpful. Thank you.
No, not at all. As part of planning guidance, all trusts were given, I think it's 2% inflationary uplift for non-pay, which included inflation, energy and all inflationary issues on our non-pay budgets. That was subsequently very clearly demonstrated to be inadequate in relation to the wider pressures that we're seeing. The NHS then made available a further 1.5 billion to support excess non-pay inflation. That amounted to, that's a considerable sum, but that turns out it's about £5 million for us. And at the time that was allocated, we believe that probably was broadly adequate based on the understanding we had at that point, and that was back in July. The world is moving on, and we are anticipating there will be significant further pressures in relation to inflation over and above that, particularly on energy. But we also need to remember that will flow into other things. All of our suppliers use energy. A lot of what we use is based on plastics, etc., etc. So therefore, we should expect that wider inflation to land. And we are seeing significant requests for inflationary pressure, not just at Epsom and St Helier, but across the whole of southwest London in terms of our procurement environment. That isn't just sort of energy inflation, that's coming from the wider sort of challenges in, let's call it, the global supply chain as well. And so I think this is an issue that we will need to maintain significant focus on. So it is a risk to our position. Where it ends up, I don't have a crystal ball, unfortunately. I wish I did. But if I did, I probably wouldn't be here.
I mean, that's understood, and thank you for that. I mean, I just wonder, Jenny, I think what we've heard is only partial assurance that we're going to have sufficient cover from inflation in general, but energy in particular, and whether or not that issue is logged at the right levels within London and more generally, and whether or not some further request for clarification, shall we say, might be helpful at this stage, or maybe it isn't.
It is a point of conversation, certainly, within Southwest London, in London, and I think, national teams are acutely aware. These conversations are happening in all trusts, I think.
I don't think we need to flag it up. I'm confident that they're very well aware of it, and they'll wonder what we're doing if we flag it up, I think. It would seem an unusual thing for an individual trust to do. Right, but a helpful conversation nevertheless, thank you. So if we could note the Finance Committee report and move on to the People Committee report, which Aruna has very kindly agreed in Martin's absence to take us through. Aruna.
Thank you. I will just ask you to help me if I'm stuck. We had 2 meetings in July and August, and we started out actually with the corporate risk register and the emerging risks. And as you can see, there is a picture there really of the risks as they stand now. We have challenged some of that, and of course we are working through an upgraded risk register. We also then looked at the workforce key performance indicators and really want to align what we're seeing with the KPIs to the risk register. Again, that is work in progress, and we expect to see an upgraded risk register really in September. We walked through the workforce improvement plan with particular focus on recruitment and retention, and very helpfully actually we had a deep dive into recruitment and retention at the committee, which of course will then feed into the workforce improvement plan. So we will be monitoring the workforce improvement plan as we move forward. The payroll dashboard, we're seeing an improving position. The DBS issues that we raised last time, again, an improving position. Work to do still, but monitoring it and good progress being made. We have this group learning and development report. We're going to continue really with our program of respect in terms of developing our managers in following through, managing with respect. We were also presented with the RES and DES reports. Again, some good news, some not so good news, as you can read, but an action plan related to what we're going to do about it, expected again in September. good staff health and well-being report. Again, good progress, and again, it's to watch that space. I guess perhaps the cultural engagement and inclusion program is probably something we should touch on. Maybe, Saskia, would you like to give us an update, the latest and greatest on that? Or
Can I make a suggestion? Shall we finish doing this, take any questions, and then Saskia could do that?
Sure. So
yeah.
yes, I mean, I guess, lots of progress on the culture engagement inclusion program, lots of interest in terms of culture champions. We're going to recruit 15 through an interview process. And then, as a matter of form, we looked at medical revalidation. That is in our commitment, in the papers going in this meeting, so I won't dwell on that. And I think that probably covers the pod piece. Any questions?
Okay, any questions or comments from colleagues before I ask Saskia to deal with the point that Aruna raised? No, over to you then, Saskia. Could you also, I just had a query about when the RES and DES reports are going to board. Do you know? Can you deal with that at the same time?
Okay.
Thank you.
So you didn't need help, Aruna. Just in terms of things have moved on, which I think is obviously good, and it's worth mentioning. So in terms of DBS, we're down to 39 non-responders now, and that might be even lower today. So we're absolutely moving in the right direction. In terms of health and wellbeing, what we have seen and we consistently see is an increase in uptake of the staff counselling service, which is, it's a bad thing, but it's good. And we see that those that are accessing are representative of our workforce. So they're from all backgrounds and more male colleagues as well. And the Culture Champions training has been completed now. But our Chief Executive, she leads and chairs that CEI board, so the update will be far better coming from her, Gillian. Sorry, James wanted. In my view, but James wanted.
It's fine. I met the Culture Champions actually. I think it was this week during their training. So we've got a variety across the trust, and they're really quite excited. And they'll be interviewing us all soon as well.
Look forward to that.
Yeah. So that's great. And we've started a programme where each of the networks report on a rotating basis through that. So we shall start pulling some of that through to the people committee as well. So they get a chance to shine in each of those meetings. So it's the beginnings of how we move this forward in a consistent way. And I think the bit for me is about how we constantly garden, how we change our culture and look after our staff, and get the best of our staff. And I think one of the things Paul would say is that we've also appointed someone who leads on talent management for across the group now, because that's one of the, when you look at staff surveys and you look at our exit interviews, usually the top two are about not being able to progress. So that I think that will be a good thing for us to have something more systematic throughout our organisation around talent management. So there's a whole raft of stuff goes on in there, but we're sort of at the beginnings of this. This is about 3 or 4 meetings in, I would say, and with a cross-reference of staff, and just staff to be able to feel confident in that meeting to speak out, to talk, and to be able to help feel that we're trying to move things forward for everybody. So I suppose that's where we are.
That's helpful. James, you wanted to come in as well?
Yeah, so I've taken on the lead role around the staff survey top 5 theme of health and wellbeing as well. And it's really interesting when we've done the focus groups and dived in. The first theme that comes out is about accessibility to the offer. So we're looking at trying to consolidate the 2 sides of our health and wellbeing offer. So we've got a health and wellbeing lead who does a number of things. We've also got a quite comprehensive offer through OH, and bringing those together into the staff app, which we're launching in September, so that there'll be a single place that people can go, hopefully be able to book onto some of the OH-based offers as well, just so that people can get into that offer a lot more easily, because I think just not knowing where to look for it sometimes has been one of the problems. The other thing that came out of the focus groups, is going back to the theme from your visit this morning is about IT. So actually people say that one of the big things that impacts on their health and well-being as a member of our staff is their kit working. And, you know, I think that's really interesting. It's not something for which there is an easy fix. We commit as much resource as we've been able to towards making sure that we've got the right kit in the organisation. But as we move forward into the EPR programme and also look at our BAU IT refresh, I think it's something that we need to bear in mind.
Thank you. That's helpful, James. And Stephen's just confirmed that Res and Des are coming to the November board. Yeah. Any other points? Saskia, was there anything that you've covered the things you needed to cover?
Yes, thank you.
All right, thank you very much. Okay, well, we'll note that report then and move on to Quality Committee, which is you again, Aruna.
Thank you. Okay, so again, we had 2 Quality Committee meetings since we've last met as a public board. We had quite a good discussion in terms of deep dives and areas that we should focus our deep dives, and indeed HSMR is one that will be coming to us in September. There are a few issues here which, again, I won't go through the detail of, such as third and fourth degree tears. There will be a paper coming to the committee. I think one of the things that I would like to highlight is the change in approach that we're taking towards SI management, and that rather than looking at SIs in isolation, we're actually grouping SIs and looking at themes, which is really a big step in the direction of the new patient safety framework. So I think we're ahead, compared to others in that context. And I certainly think, as a committee, we were very assured this time in terms of the lens that we were using in terms of looking at our SIs. I think, it's always a question of so what. There's work to be done, but I think we're certainly trending in the right direction there. Moving on to infection prevention and control, this is our regular update, and indeed, from a risk perspective, the COVID spacing risk, we've downgraded that, and also the COVID risk in line with where we are as a country, and where COVID is, and again, this is a regular update. We have, particular focus on it. We particularly looked at, the use of PPE during CPR, and I guess it's a common sense approach that we have adopted, which is documented there. We continue to look at maternity services month on month. Again, we were 100% compliant with the Ockenden, but there have been recent issues with Badgernet, which means that there is a particular safety action that we need to do a bit more work with, but we're not alone. This is a national problem. In terms of deep dives, we did have a deep dive into falls, and as I said, we will have one on HSMR. The falls deep dive was actually quite encouraging. It made us look at specific areas and also consider whether falls training should be mandatory, but I think we've taken an approach of looking at hotspots, which is what the deep dive gave us. And indeed, in applying some of the learning to Alex Ward in particular, we've actually had a very positive result of no falls. As I said earlier, we did look at the new patient safety framework, and indeed our SI lens is very much in line with that, so more work on that. I think there is one particular thing I'd like to highlight, which is about Datex, and there may be some cost pressure on us in terms of converting from Datex to another system to enable us to feed into the new infrastructure that will go alongside the patient safety incident reporting framework. Safeguarding reports, they're on the agenda, so I won't go into a lot of detail there, and I'll let Arlene cover it as part of the agenda. I don't think there was any, corporate risk register, I spoke about that earlier with the pod report, work to be done on there. I don't think we have enough quality risks. Again, we need to do more triangulation in terms of what we're seeing from the IQPR and and therefore what we see as kind of persistent reds and potential risks. And then we had reflections on the meeting. We're still working on getting papers out in good time. So I think I'll pause with that to take any questions.
Thank you, Runa. That was very comprehensive, and it was a meeting that had a lot of meat in it, didn't it? Any questions, Anne?
So 2 questions, possibly not for you, Aruna, but on this subject. As a non-clinical person, when I looked and saw that there were 5 C. diff cases in July, that looked to me to be quite high. I'm used to them being like 1 or 2 and 5. And I noticed that you did look into that and found that there was no lapses in care, but I just wondered if there was any more assurance around that. And then my other question is around the serious incidents. I note the committee was concerned at the overdue investigations, but I guess I would ask the same question I asked yesterday, which is, are we sure that we've got an appropriate system for disseminating the learning from serious incidents so that everybody gets the benefit of what's happened, given that that's the whole point of it?
So, fair point, Anne, and both of those were challenged at the committee. I think with the C. diff, I'll let Arlene respond to that. My understanding is we looked at them and we couldn't find any underlying reasons, but I'll let Arlene elaborate on that. And the second point, in terms of the overdue, absolutely, that is a real concern. Too many overdue actions on the SIs. But in terms of looking at the SIs, I feel far more reassured that we're now looking at themes, so we can do something about it. Because I think quite often we look at specifics and don't look at the full theme. But you're absolutely right on the overdue, we've got too many.
So, Arlene, would you like to deal with C. diff and perhaps comment on the overdue? But Richard may want to come in as well, but if you could kick.
Yeah, thank you. On the C. diff, yes, all of those cases had an individual risk root cause analysis done. I think the most significant thing was that 2 of them were on one ward in particular, and there was worry that there was cross-transmission, and they weren't. They were 2 separate types, and they have been looked at really extensively, and no cause for concerns. I think it was the patient that themselves a comorbidity and antibiotics, but not really a misuse of antibiotics in this case, just that they had to have antibiotics for their care, and that has reduced back to within the range, and even with those 5, F7 and Helia remain within trajectory anyway for C. diff. In terms of the learning, so the process that's used here, both here and at George's, is that the initial rapid response review is done, and the staff at that meeting are from all the different divisions, and any immediate learning that is identified, that is even before an investigation is done, is shared by the quality governance team to all of the divisions at the same time, and then when the final report comes back, any new learning is also then shared and distributed. So we had, for instance, declared a never event a couple of weeks ago, and one of the immediate learning from that was around consent, and therefore we sent out an all staff or communication around consent, and that's even before any investigation's done. So I think there is always more that can be done. Of course there is, and the teams are always looking at how that can be done. But every attempt is made to share learning as it evolves, as opposed to waiting for investigations to be done.
Richard, did you want to add anything?
Maybe, just briefly on the issue of learning and safety culture. I think the challenge, are we doing enough around learning from incidents, is a challenge that should just keep coming. I think we should structure maybe into what we bring to Quality Committee regular updates about how we're developing the sharing of learning, and that's very much in accordance with the new national approach to patient safety. I think the answer, are we doing enough to disseminate learning and share learning, is always going to be no. And what we need to do is keep building systems more and more to cross boundaries between departments and indeed organisations. St George's started a patient safety newsletter in the last year, and the intention is this autumn to start issuing a joint group patient safety newsletter in which we explicitly show how the two organisations can share learning from some of the themes and some of the important incidents that happen. So I think that's always going to be a work in progress, but actually should be one of our main focuses safety-wise. And the other main focus, I think, is on the safety culture and trying to promote a culture where people don't feel blamed when things go wrong, don't feel finger-pointed, and feel comfortable in raising them. And which was why I made the point that I think we should commend our colleagues on the ward that we visited this morning for pointing out something that went wrong with safety there that they corrected. They were very open about that. But we have work to do in that, and I think that's one of our main cultural missions over the next year, is to promote that safety culture.
And Anne, specifically on the overdue, delayed investigations, we did ask on that. Didn't get a wholly satisfactory answer, other than it's being attended to. But it's clear that people are aware of it and efforts being made. So I suspect the committee will come back to that. Derek?
Sorry, I didn't mean to interrupt.
No, I kind of said what I wanted to say.
Can I just say two things about Quality Committee? I mean, since it's merged, it's had an enormous agenda, and there's a huge amount of material to deal with, all of which is really important. And I just want to say, I think it did come out in your report, but if I could just emphasise it, much more structured, proactive approach that has been forced on the committee because of the amount of material, and taking a slightly higher level thematic view, I think has been really positive, and wanted to congratulate Aruna and Parveen on doing that. And I think that's, as a committee member, I think that's given me a great deal of assurance, the way in which that's taken forward, and the way in which deep dives and areas being looked into are being scheduled in advance rather than just being reactive. It's become a much more proactive committee. And the second thing I wanted to say was I wonder if we use enough the mechanisms of grand rounds and clinical governance meetings as a way of disseminating information. And I wonder if there's a way to improve the connection between quality committees and the clinical education that's actually happening at the forefront. And I'm a great advocate for great grand rounds because they're one of the few multidisciplinary rather than intra-departmental meetings that we have. And I'd be keen to see that promoted more.
I think it's a really good point, Derek. You've made it before. I'm sure that Richard and Arlene have heard it, and that we'll sweep that up as part of the approach. And I would like also to endorse your points about Aruna and Parveen, but extend it also to the execs, because it's been a team effort on the part of Arlene and Stephen and Richard with Aruna and Parveen. I think everybody's worked really hard because it's a big ask with Quality Committee, isn't it, in particular. It's sometimes the agenda feels overwhelming. Richard, did you want to say anything on the grand round education point, or Arlene, other than to agree it?
I do agree. The only point I make is relatively few people attend in person, but if we develop better ways of disseminating recordings after the event, then I think it's potentially a very powerful tool for communication. I agree with Derek completely.
And the Simmons and Hellier Grand Round is actually really well attended. So I think that's one of the things that maybe we could learn and share with George, is how that is managed. But it is programmed into everybody's diaries, and that is just part of what they do. And there is a heavy quality focus on those, bringing learning from SIs. And I think the engagement from the medical clinicians is really good at Simmons and Hellier anyway, and so they attend the SI meetings, present their own cases, and are then able to share that as part of the grand round, so that they're sharing the experience of being involved, not just about the incident on its own. So I think the learning is quite rich, and the way it's done is quite rich, and we can disseminate that across the board.
That's very encouraging. Thank you, Arlene. It's good to hear. Right. Welcome, Chris. No, we absolutely knew that you'd been detained and delighted that you're now able to join us. So we've just finished, I think we're just about to finish. If there are other points on Quality Committee, if we could note that report. Unless you had anything on Quality Committee that you were worried about, Chris, did you?
Top of my head,
no. Good. Right, well, we'll move on to Sutton Health and Care. But if you like, I could ask Thurza to do it while you're unpacking, or do you want to do it yourself?
Yeah, I'll have a go.
Okay, over to you.
Thank you very much. So you have the paper in front of you, and we've divided it as commonly between that which is common to both Surrey Downs and Sutton Health and Care, and those that are separate to the two. I think, without going through the full list of them, the key things for me to bring out are, first of all, that the pressure that's felt in the community is at a level that is similar to that felt within the acute trust side of things. And that includes our stakeholder partners in Sutton Health and Care. So it's not just the community staff that we employ at Epsom St Helier, it's also the social care staff, it's mental health staff from South West London St George's, and the GP services and those that they support. There are financial pressures, just as there are on their budgets, just as there are on the acute side. Having said that, I think what strikes me, talking with people and at our committee meetings, is the optimism which people have to move forward and to provide better care and to work collegiately across all the different partners in Surrey Downs and Sutton. And that hasn't gone away, despite the pressures. People are out there looking, to work better together, but also in new ways which will deliver better care for patients, and particularly, in respect of the financial, constraints that we have at the moment. And I think, rather than go through the details of that, I think I just wanted to pass that specific message across. And I'm happy to take any questions or comments that anybody would like to raise, or if Thurza wants to add anything extra.
Let's check on Thurza. No? So any questions or comments from colleagues? Peter.
Thanks, Chris. Earlier on, flowing from a number of the ward visits, delayed discharges obviously featured, not surprisingly. And I just wondered to what extent that issue is focused on within your meetings, and do you see any glimmers of light, any ways in which, or what more might be done?
So, driving over here, I've been listening to the radio talking about America. So, an Americanism would be that delayed discharges are front and centre on what people are concerned about. There's a huge amount of work done by both to try and reduce we always have to be careful, because it's unnecessary admissions and it's unnecessarily delayed discharges. Some patients need to be in hospital. Some patients need to stay in hospital a long time. So it's not about pushing people out. It's about them leaving when it's right for them to go. The key area, and there's a lot of work done with that. There's a lot of support within the from the work that's done within the hospital staff, but also externally the support from the community services to help avoid unnecessary admissions and to facilitate prompt discharging. The key area is what's going out in social care and in the nursing homes. Nursing homes is an issue as well, because they have similar staffing problems. One of the things I would like to say is actually both within Sutton and Surrey Downs, there's very strong links with the nursing homes. But despite that, they are a separate arm of health and social care delivery, and they have their own staffing problems at the present time. And that's one part of the problem, that they isn't necessarily a bed in a care home available for someone, but also discharging people back to their own home. It's often an issue. The particular issue is if somebody needs two carers in to look after them. One carer is usually easier to find. Two carers much more challenging than for them to
provide that support. So it is, but it is absolutely everybody's focus is to support that.
Thank you, Chris.
Just, if I may, just a quick follow. I mean, given the emphasis you put on care homes, and obviously a lot were hit badly by COVID, but a lot now have been hit heavily by the energy price without any protection. So it's, if anything, that position is going to get worse rather than better, it seems. And does that mean we have to just think differently, or are there any contingency plans or what?
So I'm not sure. I'm looking at Thursday. I'm not sure we've got a contingency plan around energy.
James has indicated, so perhaps were you going to come in specifically on this, James?
So there is winter pressure funding and capacity planning in the system. And that includes looking at whether we can, for example, for the Sutton system, run some GP-led step-down beds between ourselves and Sutton Health and Care and other partners in Sutton, but actually to run some step-down capacity directly ourselves. Part of that is simply about the fact that actually it feels that sometimes we just don't have the capacity in the system we need at the moment, but for a relatively small number of patients, that is a potentially viable option to help us a little bit over the winter. All the concerns are there: finding appropriate estate, staffing it. So you know, it's not that we're immune from the challenges the care sector faces, but those are the sorts of things that we're looking at. It does remain an area of substantial concern because it's outside of our control.
Anything on energy? I thought you were going to say something about energy.
Not particularly, no.
I don't think anyone's got an answer on that, have they? Did you want to come in on energy? And then James, I suspect James doesn't want to come in on energy, but Chris?
Yeah, so it's peripherally about energy. It is about, I think, as the healthcare system, you know, the NHS, it's about building bridges with them. So yes, it doesn't help provide cheaper energy for them, but if they feel they're supported in other ways, that just may stop the straw breaking the camel's back. So we will be doing what we can, but it won't provide cheap energy, I don't suppose.
Well, the government will have to intervene, like they're going to have to intervene in all kinds of businesses. James?
Thank you. I just wanted to pick up the winter pressures that James introduced and the virtual ward. I think we rather naively assumed that patients who might be looked after in a virtual ward would have simple monitoring needs, but I think we're having an increasing realisation that this is a very potentially a very complex group of frail patients who also need a lot of community nursing support as well. And I'm just wanting to check that we've got the right oversight in terms of the assurance that we are appropriately developing the capacity and optimising the use of virtual wards to keep patients out of inappropriate use of hospital beds.
So both Surrey Downs and Sutton have steering groups that oversee the development of virtual wards. It's the strength of both that they're being taken forward as partnerships, so across all the different agencies, and they report both to the alliances, which are the provider alliances, and to the place board. So I think we have the right monitoring in place. I think we always went into it knowing it was very unlikely it would just be remote monitoring. So looking at how we have a wraparound service that includes home care and community nursing support has been a key feature of it. And I think we've been quite clear as we've reported that this is not a numbers game. So we don't want to just report the number of people that happen to have a remote monitoring device. We want to report the number of people that would otherwise have been in hospital, but we're now looking after in a different setting.
Thank you, Thurza. And I wonder, could I don't want to detain the meeting, but I'm really interested in this South West London LAS UCR CARS programme. Could we just have a little note, do you think, separately? Thurza. I don't want to detain the board now. Derek?
Sorry. I'm sure it's just sure it's just missing a bit of narrative here, but two comments. One is the bed occupancy rate is huge. I mean, you're running 99.5% bed occupancy in Surrey Downs community hospitals at the moment. And so my first question would be, is it possible to operate an optimal service when you're quite that packed? And the second thing is, what happened to Dorking Sash during this period? Because has it been closed or something? It goes to 0% bed occupancy rate. I'm hoping I'm looking at the right papers.
Derek's looking at the performance report, obviously.
Suddenly, has something closed? Because Dorking Sash has gone to 0% occupancy.
So
maybe the first question, can you operate optimally with 99.5%
I'll answer it the other way around.
Okay,
So,
fine.
The additional beds at Dorking that were commissioned by East Surrey were decommissioned at the end of March, so that fell away. So there won't be any beds from the Sash area.
So did we lose overall capacity?
We reduced capacity. We went back to our commissioned capacity. In terms of can you run at 90 whatever percentage?
9.5.
Yeah. We do, yes, and we run safely and we run appropriately, but we have a very active way of ensuring that when someone is discharged, we are ready to admit the next patient. So our coordination hub coordinates all the time, making sure that as someone leaves, there is someone to come in. And that does that has a toll on nursing staff, but it's the way that we run the service, and I'm quite confident it's both safe and a good quality service that we run.
I think it's an extraordinary achievement, if I might say so, Thurza, when other people struggle at much lower figures.
Sorry, can I come back? So those Dorking beds, will we need them with winter pressures? Will they be reopened? Or are we going to run at this lower level of bed availability?
So we did
we're so full.
We did open those beds again for Epsom and St Helier at the time of the heat wave, and they are part of the winter plan that the board will receive in terms of opening them over the winter period.
So they may come back online?
So they will come back online, yes.
Thanks.
Okay, good. Right, could we note that report, please? We're now running quite substantially behind, which, as you all know, agitates me. My plan is that 2, 3, 2, 4, 2, 5, 2, 6 and 2, 7, all of which have been scrutinised by the relevant committees, we will be able to deal with quickly. So I'm just flagging that up to you all at this stage, because I don't want us to skimp on the integrated performance report. It is a key report, but we can't drift in terms of time, and we are at risk of doing that right now. So that we'll move on quickly to 2.2 and got you all on notice for the rest, if you don't mind. Thank you. So, James, integrated performance report.
So I'll start, and then obviously Arlene, Richard, Saskia and Thurza may want to come in on relevant elements as well. So just on the urgent care performance, I think the story that you see from the July report is of an extremely challenged system in July. You will see that we actually were very effective in terms of managing the number of admissions that we had. We used our same-day emergency care extensively. We had a further reduction in our short admissions, which again shows how effectively we are managing to often manage people with the support of our community partners at the front door and maintain people's independence and support them to be treated in other settings. Notwithstanding that, we saw an increase in the time that people waited in the department for a bed. We saw an increase in the number of people who were waiting more than 12 hours from a decision to admit. What we know from London-wide research is that a 10% reduction in discharges leads to a 40% increase in the average time in ED. And what we saw in July was another sharp increase in the number of patients who were waiting more than 14 or 21 days in the hospital, or had a length of stay of more than 14 or 21 days in the hospital. It reached its highest level in 3 years, in fact. I think then the correlation with the time in ED and the resultant challenges in terms of patient experience was absolutely clear. We've rehearsed already the fact that some of the challenges with this are outside of our control, and the fact that we're putting in place some system-wide mitigations looking at the likely pressures over winter. But I think it's really important, and my focus with the team has been that we do not get to the place where we take the approach that this is purely an externalised problem. We've been very focused on our internal processes, on making sure that we are ensuring that people get the therapy input as soon as possible. We've been doing recruitment into our therapy posts. We're also looking at a wider range of therapy assistant roles that we could potentially pilot to try and increase some of the therapy input to some of our patients. We've done specific events focusing on particular cohorts. So, for example, the cohorts of patients awaiting packages of care to ensure that they exit hospital as quickly as possible, and also focusing on specific wards. So, with an expectation that there is real oversight and grip on the patients on specific wards, what they need, to make sure that our pathway zero patients, so those that don't need any external support, go home as quickly as possible. And where patients do need external support, we are doing everything in our gift, and making it as easy as possible, given the pressures on our partners, for them to support us in terms of prompt discharges. Much of August has been as challenged as July. The heat certainly hasn't helped. In the last few days, we have begun to see a few glimmers of light. So we've started today, and the last couple of days, in a slightly better position. But I would be reluctant to give the board any sort of assurance that the pressures are in any way fixed. I think that some of the focus that we've had on internal flow has given us a little bit of breathing space over the last couple of days, and that is where our focus will continue to be going into winter. I mean, I think in both the Surrey and the Sutton systems, we have as effective partnerships as I see anywhere, and I am confident that we're doing everything within our gift, but it remains extremely challenging. I think on planned care, we are in the position now where the waiting list position is stabilising. I'm very pleased about that. We are continuing to run significantly ahead of benchmark in terms of outpatient provision, and with a slight abatement in terms of the increase in GP referrals. That is meaning that on the outpatient side at least, we're beginning to balance capacity and demand, and the relatively small growth in the PTL that was seen in July is reflective of that. The challenge will be for us in terms of those patients as they track through the pathway. As highlighted in the report, there is a risk that we have then long waits for both non-admitted and admitted care later down the pathway as that surge of patients that we've seen in the first half of the year tracks through. So that will be something that requires continuing focus. There are a couple of specialties where we're particularly worried. One in particular is community paediatrics, where our clinical staff are highly committed to discharging a number of statutory roles on behalf of 2 local authorities, as well as their clinical work, and we're in active discussion with the local authorities about how we try and release some more of our clinical staff's time to see the patients that are being referred in, because there is a huge pressure on that workforce. I think it's worth highlighting that in cancer, we had another very strong month of performance. We continue to see some external delays with diagnostics, but otherwise it was a good position for the reported month.
Thank you, James. I think the board would want to thank all the staff in both the emergency and planned areas, because I think they've done a fantastic job, and we should, I think, thank Debbie for holding the fort until Alex arrived. She did a fabulous job. I hope colleagues would join with me in endorsing that, and a big welcome to Alex, who certainly hit the ground running, didn't he? Any questions to James? No? So, Arlene, was there anything you needed to flag up?
Thanks, Julian. And I think from the quality perspective, it was just that we have the metrics on the quality page this month, which we didn't, and we're still working at refining that, but we've got the dementia there, and we are looking at ensuring that we're able to include the must scores, but no big stories coming out of the quality for this month.
Okay, thank you. Any questions to Arlene? No? Richard, anything you needed to flag up?
No, I don't think there is, actually. I think
okay,
we've discussed.
Right. I know we've talked quite a lot about quality issues. So, Thurza, anything that you particularly wanted to highlight? Thank you. And last but by no means least, Saskia, anything that you haven't had an opportunity to flag up yet?
If I may, in terms of sickness absence, we are about to start a complex case clinic, so we've increased capacity and capability in that area. Our focus continues on appraisals for obvious reasons, with detailed data and business partners now enabling their divisional management teams by actually allocating dates for appraisals where they're outstanding and monitoring that on a very regular basis, and also providing coaching. So, and not just kind of death by PowerPoint, but actual coaching in terms of making them meaningful and making them quality, so we're not just driven by compliance and people don't feel that they're just driven by compliance. In terms of vacancies, there is a focus. There are many areas of focus, but there is a particular focus following on from the Workforce Improvement Programme and the deep dives on the estates and facilities, because that's quite high, and the People Committee spoke about that, and we're working up a detailed plan which we will report back there. And in terms of onboarding, so this will start to look at the stability index, those that leave within the first 12 months, implementing a questionnaire that will speak to people about their experiences over their first 6 weeks, so that we can start to deal with any concerns that we're able to, so that they don't psychologically check out quickly and then they want to exit. So thank you.
Thank you very much indeed, Saskia. Any questions for Saskia or comments on people issues? No? Thank you. So we're asked to note the report alongside the reports from the relevant committees, where we've heard some more of the detail about the successes and challenges. People are happy to do that. Lovely, thank you. So that takes us on to 2.3 and the maternity services perinatal quality surveillance measures, July 2022. It's quite a mouthful, isn't it, Arlene? And we looked at it at Quality Committee. Over to you.
Yes, thank you. And I'll just take the report as read. Just a couple of things to highlight. This is one of the requirements for the Trust to meet its CNST obligations to bring this report monthly. In terms of highlights, it's 12 perinatal mortality cases, and they are all looked at individually to identify any causes of concern, and there haven't been any identified. As such, we've had no SIs in that month. There are still 3 cases that are open to HSIB, the Health Safety Investigation Branch, and that is as per requirement under the new process for looking at these cases. I think the concerning thing is that we have 2 outstanding actions, and they're both from 2021 for the team to complete, and they have committed to ensuring that those are completed by the end of August. So we should be reporting that they're done, in the next one.
Thank you, Arlene. Any questions on this, Chris?
Can I just ask, Arlene, how timely are these HSIB reports? Do they take a long time to come back to you, or?
Yes, they take a long time.
And that's problematic, is it? Or do you feel that up to now you've covered the issues with your own internal work?
Yeah, so I think that's the thing, as we said, we were talking about SIs earlier, is that the team will do an initial look, a rapid response review, and will ensure that any early actions are undertaken. And HSIB, we tend to have identified the same learning points by the time their report comes back. So it's not that we're missing anything while we're sitting waiting. We do our own internal.
So if there are no other points, we're asked to note the report and that future reports will include progress made towards meeting mandatory training performance targets. I think that latter point's quite important, isn't it? Because some of the figures are much lower than we would want to see, Arlene, aren't they? People happy to endorse that? Yeah, thank you. So that takes us to 2.4, which is the Responsible Officer Annual Report, again looked at Quality Committee. Richard.
It's a very comprehensive report. I didn't want to talk about it in any detail. I did want to thank Steve Heyer and Laura Neal, because I think if you read this you can see just how much work goes on to appraise our doctors. It doesn't happen on its own, and I think you can also see from this report that there's a real concern about staff well-being. And it's not just a mechanistic report about numbers, it's a report about how people feel and how they're looked after, and I think that tells us something about the team that's doing this work. So I think it's very commendable that we only had 8 deferrals out of 202 recommendations to the GMC. That's in contrast to St George's, and although I don't think that the number of referrals at St George's is necessarily worrying, it's interesting to think where the opportunities are for us to learn from each other. That's, I think, all I wanted to say, really.
Thank you, Richard. Very nicely put, if I may say so. I thought it was an excellent report for all the reasons that you highlighted. Anything that anybody wants to ask about or...
Can I just ask one question?
Of course.
We talked yesterday at St George's about a new appraisal system going in. Is that happening here, or have we taken what's here and put St George's?
There's going to be a new national approach, although I'm not sure we'll notice it as exceedingly different, but a new national approach to appraisal. That will be the same here as it is at St George's. The platform through which people are appraised is different, but the overall approach will be the same.
Okay, so there's quite a long list of recommendations. I don't propose to read them all out. There's about considering and noting the assurance provided, which I think we've very strongly got. I think it's worth noting the positive feedback from the higher level responsible officer quality review, because that can't be taken for granted, can it? So I think really well done there. I think we are committed as a board to supporting the progress, and delighted that there's been so few deferrals, and we required to delegate authority to the chief executive to sign something off.
Yes.
Yeah, we're all happy to do that. Lovely, thank you very much. So that takes us on to 3 annual reports, all of which have been through Quality Committee, and the first, item 2.5, is the Infection Prevention and Control Annual Report. Could I just say, Arlene, I thought it was an excellent report, really quite outstanding. I didn't actually say that at Quality Committee, but so thorough, and so my thanks to those that were engaged in pulling it all together. But over to you.
Thank you, Gillian. Yes, I will ensure that Pradine, who does all of the work for this, that is handed over. So I will take all of these reports as read, because, as I say, they have gone through the committee, as you've said, and they are here in their fullness. In terms of infection control for Epsom and St Helier, COVID, of course, continue to dominate in terms of infections that they have been dealing with. However, there are others that we are required to also monitor and to keep on top of. And of those, C. diff, Epsom and St Helier ended the year below trajectory, which is highly commendable given everything else that we identified in the year. Epsom and St Helier also ended the year with 0 MRSA bacteremias, second year running. Given prior to that it was considered almost unachievable to get 0 MRSA bacteremias, but we've done it. So that's really good reflection on the work that the team do and that everybody gets engaged in. There was major issues that the team had to deal with, and one of those was aspergillus in ITU, where a number of cases were identified. I think that the work that the team did, the infection control, but also the clinical teams in ITU working together, were able to quickly understand what the issues were, and now the ventilation issues feed into the estates committee that has been set up, and I think that was a real good outcome, if you like, for having looked and having to deal with the aspergillus, which I wasn't able to pronounce, I think, when it first. Now we know so much about aspergillus, it's unbelievable. Aspergillus they had to deal with, and they also had to deal with Legionella and high count of Legionella in Epsom theatres. And again, as you've heard, those are 2 of the big water and ventilation are the 2 big issues that are being looked at through the Estates Committee. So overall, I think, as you said, Epsom and St Helier have continued to do really well in the infection control and prevention and control space, and we will continue to work towards working together with George's moving forward.
Thank you, Arlene. Just let's check whether there's any questions, or everyone happy with this report. I did think the aspergillus and things were covered really well. Again, my thanks for that. Right, so we're asked to receive the report and note the priorities for 22-23. Yep, which we're all happy to do. Right, so that's 2.6, the adults safeguarding report, Arlene.
So, yes, thanks, James. In terms of the adult safeguarding report, which has been read, I think the things to highlight is that referrals for abuse continue to be consistent, but I think the team do have an underlying concern that a lot of it is being hidden with COVID, and that, you know, there might be a little explosion somewhere where it all starts coming back and people start going back to normal life. So they keep an eye on that. The Liberty Protection Safeguarding System is being introduced, and that will replace what we currently know as the DOL system. And there's work, Epsom and Elia are ahead. They have actually recruited somebody to lead the implementation of that program. In terms of areas of concern, training, particularly level 3 training for both adult and child safeguarding is a concern, and the team have a recovery plan for improving that. And one of the big things for this year was that the team were able to recruit a learning disability nurse, and that was funded by the local authority, which is great news, I think. And we already have support for learning disability patients in Epsom provided by Surrey Borders. But that was a real struggle for a long time. That is all for the adult safeguarding.
Okay, let's check whether there's any questions or comments. Really pleased, you know, I've always had a thing about the learning disability service here, Arlene, so really pleased to see that there's been some attention there. Probably we could do with more resource, but that's the story of our lives, isn't it? So we're required here to, well, I think we can take assurance from a very thorough report. I'm not going to read it all out, but I think we can receive the report and note the priorities, yeah?
Yeah.
Great.
Thank you.
And then 2.7, the Safeguarding Children Annual Report.
Yes, and the children safeguarding, just like we heard yesterday at the George's board, children and young people admitted with mental health concerns have continued to rise, and in Epsom and St Helier we had 980 of those children seen through our EDs mostly, and you know, it's about 50-50 with 502 of them being seen in Epsom. The good thing is that we do have pediatric nurse support in Epsom, but not in St Helier. So it is something that the team is looking at as well. And CAMS, we do have really good support for CAMS in St Helier, but not so much in Epsom. So you know, the children get seen and assessed and reviewed and whatever they need provided. But we have had, the process is that the child comes in while they're waiting for that review and assessment by either CAMS or whoever is going to see them. They are admitted to the ward, and that can be very disruptive for the staff and the other children on the ward and the parents, and it does cause a high level of anxiety, and we have put in a lot of training for staff, which we wouldn't normally in a, you know, if you're thinking an acute hospital, disengagement training and all of that, pediatric nurses, you wouldn't have to do that, but we have had to do that, and it continues to be an issue for the trust, but I think it's also a national issue, but I think Epsom in particular has really struggled, and so that does take its toll on staff. But from a safeguarding perspective, we have, the teams have worked really, really closely with ED as well to identify patients, that children that might be at risk, and that is even, you know, if an adult is admitted with alcohol abuse, for instance, the ED team are now thinking, is there a child in that house? And because of that, we've been able to do quite, I think, over 3,000 information sharing opportunities, which is a system that we use to ensure that partner agencies are aware that there is a child maybe somewhere that's been affected by this. Level 3 training remains the challenge, and the team have a remedial plan in place. But we think, and we were talking about this yesterday on our walk, that the training we need to review actually, because it is quite difficult. People want to do the training, but the training that we have available at the minute is so difficult. Even me, who's done safeguarding for years, it finds it difficult to achieve the assessment at the end, which bears no relation to the actual training. So we are going to be working on it.
Thank you, Arlene. I'm also very conscious that it's a while since the board's had any safeguarding training.
Yes, yeah. So we are working on getting that to board
That feels like a real priority
Yes.
to me. I'm sure it's on the list, Stephen, isn't
It
it?
is, yeah.
Thank you, Arlene. Any questions or comments on this report? Another very thorough piece of work. We're asked to receive it and note the priorities. Yeah. Thank you. Well done, everybody, because we're caught up with time, so I can relax a bit again. It's now item 3.1 and the finance report. Andrew.
Finance report, I think I've used this phrase here before, as a good news, bad news story. The good news is we're on plan. The bad news is that plan is to report a deficit of 15.3 million at this point in the year. So we're doing what we said we'd do, but I think what we said we'd do is an illustration of the challenges we face in the current financial year. I won't go through the reasons for the deficit. I think we know those quite well in terms of the scale of the planning challenge that we have. I think it's worth pointing out that, as we move into towards the second half of the year, we should expect that challenge, to increase. We have a significant amount of unidentified CIP within our plan, as again we've reported here before, but that will begin to tail more specifically on our financial position, because while we are on plan at the moment, we should expect to, if we don't address that unidentified CIP, to begin to move off plan. So not only will we have a deficit, but we will have an adverse variance from that deficit as well. And we should expect to see that coming through. CIPs, I think, it is worth saying, and James will probably reiterate, there are challenges, but we are seeing, improving engagement and continued improvements in engagement from the divisions in supporting this. It is never welcomed to get into the world of CIPs, but divisions, I think, are beginning to engage in the challenge. There is the scale of the challenge, again, as we've discussed here, is something we are very, very conscious of in terms of how we go through that. Cash is another point worth noting. As Anne said, we are focusing a lot on cash. We believe we have sufficient cash to get through the year. I'm not worried in the sense of we will run out, but as a board, we have a responsibility to understand our cash position and how that's managed. So we will up the level of detail on that within the finance report. And there was a separate cash report which we will continue to expand so we can focus on that going forward. Obviously, the key issue for us relieving pressure on cash is to get closer to the balanced financial position and thereby addressing the unidentified CIPs that we currently have. So we'll continue to focus on that. Capital, we are broadly on plan. But the pressures that we've previously outlined, still exist within the capital programme. It is significantly, demands significantly exceed our resources, and the resources are already overcommitted.
Thank you, Andrew. Questions for Andrew, or comment, clarification, something, James?
I think just the only comment that I would add, particularly in relation to CIP delivery, is to note that the inflationary pressures in the wider economy, and particularly in terms of cost of living, are a significant risk to a number of our CIPs, for example, particularly around temporary staffing rates. We've done a huge amount of work on temporary staffing rates, and the more work we do, the scope for reducing these in a way which both leaves the hospitals safe in terms of their staffing, but is also leaves our staff with a fair rate of pay in the current context, actually is less than we thought. And I think that's going to be a significant pressure, because that's absolutely one of the first places you look in a SIP programme, but it feels very, very difficult in the current context, and there are no easy decisions to be made in that sort of area at the moment.
Thank you, James. And that will be felt across the NHS, won't it? Because those kind of SIPs will not just be in our plan, as it were.
Well, indeed, and I think one of the issues, Gillian, if I may, is that we are actually seeing some organisations increase some of their temporary staffing pay rates around us. So then we have a really difficult balance, because if we see organisations increase their temporary staffing pay rates, then if we maintain or lower ours, then the risk is that either we can't get enough staff or that we're pushed into agency staffing, which is of course more expensive. So understanding what the right thing to do for our staff and what I think the right thing to do for our organisation is becomes a lot more difficult. So yes, we're absolutely, it's not a problem that we face in isolation, and we're also interdependent on what other organisations do.
Is there a South West London agreement?
Well, there sort of is and there isn't. So we try to step together with it, but we're all starting from different points anyway on the pay rate. So that's the first bit. So if trying to find a way of equalising them in some way is quite difficult. And then one of us will say, I've got a really big problem with X, and if I don't pay Y, I'm going to end up with either harder patients or serious problems in their service. And so then do something different. So we try to, but it's just not easy, because people end up going out for a variety of reasons, and we're not all starting from the same base. And actually Epsom, St Helier and St George's both have higher pay rates, I think, than everybody else. Is that right? Or is that in some areas and not in
some
others?
areas?
Yeah.
There are huge numbers. You know, when we talk about pay rates, we're not talking about 5 or 6 numbers. We're talking about hundreds of numbers in each organisation. So we are up and down, across the board.
But if I may, I think one of the problems is that we certainly did at ESCH when we started looking at this, and then at least 2 organisations near us have changed their pay rates subsequently. So we're increasingly tracking towards the middle of the pack.
It's enormously difficult. So it's both a SIP challenge and a run rate challenge, presumably. Because I've always felt that if we could stick to our run rate and then have an explanation around the problems on SIPs, but if we start being challenged in both, it's really hard.
The headwinds are getting stronger.
Yes.
To achieve.
Yeah.
But I suppose the bit for me, the bit that really sits within HR, which we've started, is trying to, we've seen our vacancy rate come down, which is good.
Yeah.
Because it was not so long ago really up near the 18%, I think, wasn't it? So that's really good that that's coming down. We've talked about how we're trying to stop the outflow of staff going. So, how do we really make these, our organisations a great place to work and resolve issues early on in people's career with us. We've talked about talent management to try and keep people with us as well. And then I think the bit for me is how do we actually, get to a point where we're not, and we talked, for me, the bit about sickness and the bit about leave management is pretty critical, because those are the 2 areas. I think Saskia talked about something really put across both organisations around sickness management, because we got out of kilter with doing good sickness management, and then also the other thing I just said, I've forgotten what I said, sickness management and also and then the leave management, because that still is the rotating. The nursing tends to be better, but we know there are places that we still need to manage. But we've got quite a lot of unrotated areas that actually it's difficult to oversee and a bit of consideration. So there's some things about good practice that gets us to wanting to use, let's say, back in agency stuff, that actually we need to focus on rather than it per se, I think.
Thank you. All of you have contributed. That's really helpful. Any other questions from colleagues? So we're asked to note the report. That takes us towards the closing administration. There is no any other business that I've been alerted to, so I'm assuming that means there's none. Because we're back to normal pre-COVID behaviours, we've got time for a proper reflections on the meeting, and I've asked Richard if he would lead us through that. So Richard, over to you.
Thank you, Gillian. So Yeah, a couple of things. So my first reflection is on how we began the morning before the formal meeting started. I think it's really positive that we do the walkabouts that we do. I said that yesterday in the Georges meeting. I think it's a great way for us to get to see and feel and touch the organisation. And it's really interesting listening to the feedback. I think is valuable. I thought the papers were quite good, and I don't always think that's about every meeting I go to, but I thought they were well written and interesting to read. I thought it's very helpful to have the reports and the discussion around Sutton and Surrey Downs, and it reminds us that we're much more than 2 hospitals. It's a broader organisation than that, and I think it encourages us to think about healthcare in a broader way than just a hospital-based organisation does sometimes. I thought there were some points where we can be reminded that the group is probably gradually getting more mature, and the discussion around quality committee, I think, reflected some sense that we're starting to come together a bit more between ESTH and St George's, and there are opportunities for shared learning, which I think is very positive. I think, if I may say so, that Gillian gives us a very good role model for how a chair keeps time. And I was all ready to ramble on about my paper, but I was far too frightened to do so after Gillian said what she said. But it's one thing for a chair to say we've got to speed up. It's another to say here is where we're going to take our time, here is where we can go through quite quickly because it's already been discussed at a subcommittee. I think that's very helpful. I think I wouldn't want to overstate this, but it strikes me that there isn't an awful lot of executive challenge in the meeting. I think a lot of the challenge comes from the non-executives, and I thought that the quality of the discussion was good and the challenges were all good. I just wonder if, in a unitary board where we've all got the same responsibilities, really, some of us are execs, some are non-execs, but maybe, and I'm thinking of myself as well, maybe we need to get more into a rhythm of challenging each other. Just a thought, I wouldn't want to overstate it. Those are the main things, and if it's not frivolous, my last thought would be we're all quite soberly dressed in muted colours. And the St George's board yesterday was far more colourful. And no, you're the least muted. But I just wonder if that reflects something subconsciously about how we prepare for different boards with different feelings. Just wonder. I'm going to come in bright clothes next time.
Well, for those who didn't see yesterday, Richard had a bright pink shirt on, so he's certainly more soberly dressed. Thank you, Richard. That was really helpful. I wondered, did anyone else have something to say? Because, well, while you're thinking, I wanted to pick up the Sutton Health and Care point. So I'm not sure we give it enough attention on the board. And I'm not sure we do it in the right place, because it's not, the two boards you chair, Chris, are not formal subcommittees of the board. And so I've always thought this, but Richard, if you like, has provided the opportunity. And indeed, I said to Thursday I was going to raise it. I was going to raise it under the item, but we were a bit pushed for time, so I didn't. I think it's worth us thinking about how we enable a fuller report back and have better discussions. I think Chris and Thursday do their best, but they're squeezed against other things. And there's always loads in the report that I want to ask questions about, and we always seem too tight for time, really. So Thursday, it would be interesting to know what you think about that.
I've always found it quite confusing because community is absolutely wrapped into all of the other subcommittees and it needs to be seen in that way. But I take Richard's point that actually a lot of the advantage of having that role within Sutton and Surrey Downs will get missed if we didn't have a report. So there's something about a different type of report for me, and maybe not at every board meeting, but something that would focus more upon that wider partnership and the role that the group is playing in the wider partnerships would be really helpful.
Yeah. Chris?
I think that's right. So, I mean, quality issues are looked at through the quality committee. To be honest, I don't know if finance is looked at in the finance committee, but I think we certainly get support on the finance side. I think for me there is something, as Thursday says, about using this to demonstrate the wider picture that's going on in Surrey Downs and Sutton, and how that fits in with Epsom St Helier. And it would be good, it's obviously being made up of various stakeholders, it's complex to explain all the ins and outs, but it would be good to try and find a way of doing that over a period of time. So yeah, no, happy to look at it in a different way, absolutely.
Well, I think it's for all of us to think about how we do that most effectively. But it always strikes me as say it's squeezed in the wrong place, really. So thank you for that. Any final points, Anne?
I was just reflecting, having come hotfoot from the Georges board yesterday, that we take things in a different order at this committee, and which led me to think, which one do I think is more effective? And I actually think taking all the subcommittee reports together is actually more inclined to focus the board on assurance than getting into too much detail. But I just thought it does give a different dynamic to the board.
No, it is quite striking. I've got used to it now, but when I first arrived here, I found it quite confusing. Not confusing, that's the wrong word, just different, I suppose. So something to think about as well for the future. Any fine? Oh, Peter, yeah.
Yeah, just about the interface with the ICB, Integrated Care Board, which is now getting more established. We don't hear a lot about what's going on. I'm not saying I necessarily want to, but it's just in what ways can we, in terms of the interface, where are the tensions, where are the issues, in what way can we look to be developing those wider links in as constructive way as possible? It just may or may not how far that should be discussed in this board. I'm not clear. It's just asking the question. It's a key part of the new structure.
So we have a quarterly report, don't we, which James presents?
I think from memory that might just go to the St George's board historically,
No,
but did it come to the Epsom St Helier?
Historically it only went to, but we brought it last time
But
here.
I think it is helpful
Yeah.
that this board
Yeah,
is
no,
cited on that external interface.
I think Peter's right, it's a really important point, but I think we've got it covered on the quarterly report. I don't think we could have it more often than quarterly.
No, I agree with that. My only qualm with some of these reports that they can come across as very very kind of quite bureaucratic, and it's just trying to find a way to get the engagement, where are the challenges, where are the rubbing points, to be more open in a sense about where the challenges are, rather than just reporting back, as it were, on the formal part.
Might be a place for private board.
Exactly.
So we'll think about that. Thank you. That's a helpful suggestion. Yes, of course.
It would be helpful to do that for the places as well, as you said, because we don't get a lot here at the board about the places either, and I think that places could be a real thing. James chairs the place for Sutton, those that chose the place for Surrey Downs, George's for the George's conurbation for Merton and Wandsworth, and we sit on it, but we don't chair it. But it doesn't feel like we bring it comprehensively together about place and the part we are playing in there. Yeah. And then that will also feed into the anchor institution conversations we need to get more into. Yeah. So I think that would be a bit of just to expand that a little bit. I think.
Well, let's have a think about how we do that most effectively.
Long reports or anything.
No.
Short,
Yeah. Okay, thank you very much for that. They're good suggestions. But James, you wanted the final word on this.
I know, I was just going to say that with two members of this board also being members of the ICB, I think there's opportunities when we do bring that report to hopefully lend a bit of context and a bit more than perhaps just the written report as well. Yeah.
And there's also the ICP, of course, which I sit on. So lots to think about there without overloading the board. So we'll take all that away. Thank you. Right, I'm going to move on to the staff and patient story now, and welcome, I hope, Teresa and Nadine, is it? Yeah. So would you like to come and sit much closer to us? And Teresa is the Deputy Chief Nurse and Nadine is the Associate Director of Nursing for Paediatrics. Have I got that right?
Absolutely, yeah, thank you.
And you're going to talk to us about how we altered our practice because of a complaint. Sorry, hang on a minute. No, we do the staff and patient story. Yeah, sorry. Chief Executive just challenging my running of the meeting.
Sorry, ladies.
But I'm in charge.
She is. I can vouch for that, she's in charge.
Right, over to you.
So I'm just going to talk through really a complaint that initially came to us.
Are we going to be able to, I'm so sorry, are we going to be able to hear you properly? Would you like to use a microphone?
Can do.
No, just pull up your chairs near. Chris, you don't need to move. I'm sure those, you can both move and stay there and use the microphone.
Just the talking anyway, that's all right. Okay, can you hear me better now? Yeah. Okay. I'm basically just going to talk through a patient complaint that we received earlier this year that initially came through as a PALS complaint to one of my paediatric matrons. It involved a parent who was admitted one evening onto the paediatric ward with her young baby, who was about 4.5 months old, into one of our cubicles. The mum, during her stay, felt quite strongly that parents should be provided. She stayed with us for 3 days on the paediatric ward. During that time, she was in a cubicle, the child was receiving care, and there were no other family members that were coming in to support her at the time. And what mum had picked up and realised was that mums that were breastfeeding, so there was another mum next door that was breastfeeding in another cubicle, were actually being provided with a meal, whereas actually non-breastfeeding mothers weren't being provided with a meal. So her complaint centred around that she felt that she was being discriminated against because she was not breastfeeding her baby and was therefore not being given a meal. So initially the response went back to PALS from our paediatric matron that, it had been this practice had come into effect probably about 4 or 5 years ago at the time when the Trust was going for Baby Friendly Initiative accreditation, and it was seen as very much supporting mum. So by supporting mum's nutritional needs, it was then supporting baby's nutritional needs. The mum obviously wasn't happy with that response and decided to move towards a formal complaint, of which I was then asked to look at and to reallocate. And I think it raised a number of issues, and everybody that you talked to about this had a different view on it. But alongside that, there was some work going on with the National Children and Young People's group, actually around looking at parent meals whilst they were resident with their babies and children on paediatric wards. And there was also some changes internally around what we were able to provide, or the facilities parents were able to access whilst they were staying with their children, particularly out of hours. So there was already some work going on within our own catering department, and there was actually a national survey going around to all paediatric units to look at scoping what other areas do. So I was able to pull together some of that information, and I was also able to contact, with the support of the catering team manager, some of the other areas to see what they did. Did they all feed all resident mothers, or didn't they? And overwhelmingly, majority of areas weren't feeding resident parents. So we were then kind of faced with the situation: do we stop altogether, or do we look at things differently and see whether or not we can support parents? And I think, I've been there at night when a parent's been admitted, been sitting in A&E for 8-10 hours, they haven't received a meal, they've got no family support, they might have left their purse at home, all of those things, and how do we actually support them for what is a really stressful time when you're being admitted with an unwell child. So we looked at our practice, and one of the things that was coming up was that we were able to get microwave meals that were wholesome, nutritious meals provided from our catering team at a reduced price for families that found themselves in that situation, really. And this complaint also came in during COVID, so our visiting was very limited on the paediatric ward as well during that time. So we were already kind of coming up with some solutions, but there's also going to be those times when parents are admitted with their children where they don't have the means to pay for whatever reason. So we wanted to kind of think about something that was going to be flexible and meet the needs of everybody. We then decided that actually we needed to kind of get the views of our Trust Equality and Diversity lead as well, to see whether or not they did feel that there was a discriminatory aspect to what we were currently doing. And again, as I said, everybody's got a view on it, and we've looked at things from both sides. But
we then had to consider what was going to be the right thing to do going forward on both sites, because we've got a paediatric ward on both sites for families. Given that there was now an option available to us from the catering department to have low-cost nutritious meals being provided, or for us to order meals and perhaps charge them against our ward budget in exceptional circumstances, we felt that actually we needed to ensure equity across all of our parents, that we shouldn't be saying that meals are just provided for breastfeeding mothers. We needed to look at it from an equality perspective, and actually what we then went on to agree was that any parent where there is an identified need, and you could say an identified need again could be up for interpretation, but we have given examples to the ward team, a meal can be ordered. If a parent does not have the means to pay for those meals, then obviously we will provide that meal for that resident parent at that time. So we've put all of the steps in place. I have to say, since we've done that, there hasn't been a huge uptake, or there hasn't been a great need identified, but I think it is there, and what we're now not saying is you are only provided with a meal if you are a resident parent of and breastfeeding, which I think is the right thing to do. And actually, had this lady not put in that complaint, I think it's like everything, you carry on custom and practice, and we would have carried on doing the same thing because that's what was agreed however many years ago. So I think initially when we did the formal response back to the parent, she still had a number of questions and then asked for further clarification. At that point, I actually chose to ring Mum and speak to Mum myself. And actually that conversation was incredibly helpful. And I was then able to answer all of the mother's questions that she had. She wanted to know how we were going to evidence it, how have the staff been informed, if she came to the ward and she asked for a meal, would she be provided with it? And we were able to give her some of that assurance. So actually through that conversation, I was then able to diffuse the complaint, and I think that mum felt that she didn't want anything out of it other than to make it better for other parents that were in the same situation that she was in. And I think it was a very positive outcome and something that hopefully will benefit lots of parents to come on the paediatric ward. We've still got our ear quite close to the ground with the National CYP programme to look at what the outcome of the national survey is around providing residents, parents with meals, but I think we feel comfortable with the decision making that we took and felt that it was the right outcome and something that actually this complaint had a positive impact on. That's it. Thank you.
Well, that's a great story. Thank you very much indeed. And so commendable that you were prepared to look at. It's so easy to say no, isn't it? It is. So easy to say no. Any questions? Oh, lots of questions. So James, Arlene, and then Anne. Oh, and Aruna. Right, James.
Thanks for sharing that, Nadine. It was really interesting. And as you were mentioning it, we started doing something for good intentions in order to achieve baby-friendly initiative, but it made me think we need to take a step back and look at all of our metrics that we use to assess our performance and the quality of the care, because we change our behaviour according to what is being measured. And it feels really important that we use opportunities like this, but outside these opportunities we should proactively look at what's being measured for our departments and think, are we measuring the right things? And is it really reflecting the quality of care and the patient experience and the carer experience optimally? So thank you for sharing that. It's made me think about our metrics.
I'll take all the comments and then perhaps you'd like to come back. So, Arlene.
No, that's fine. Yeah, because I was involved in this because it came to me, and I think the thing that struck me was the initial response, because this parent had gone to PALS, and a junior member of staff had responded to say, that is our policy here, and the parent demanded to see the policy. And I think,
And there was no policy.
And there was no policy. So this was a tenacious lady, but I think the learning for me is also about who gets involved in ensuring that the right people provide the response, and that, because that junior member, in her head it was a policy, that's how she'd always seen it. So in her head it was a policy, but we might have had the opportunity earlier to think, actually, and do all of the stuff that we have now done without it going to a complaint in the first place. and maybe that, you know, would have started with a call to the parent. So I think that, you know, a lot of learning, and we've made the changes, but I think we should also recognize that as well.
So I was pretty much in exactly the same place as Arlene. Clearly you've kind of rescued this and actually made it into a good outcome, but it's, do we, when we receive feedback, are we open-minded enough to say, actually, they've got a point? Because I think you head off a lot of complaints if you listen properly in the first instance. And I'd be with Arlene, I'd have been on the phone earlier in the process, I think, which is what delivered a really good outcome, isn't it?
Right, I've got Aruna and James.
So I'm just building actually on what James said. It affects me a little. So we are baby-friendly group, and one of the criteria is really, I suppose, incentivizing those that are breastfeeding, right? But in doing so, are we absolutely certain that we're not crossing a barrier from an EDI perspective, and overlooking? I mean, there may be moms that can't breastfeed, that they're not, given that word. So I think it might be a good idea to just really look at, those criteria. Really, it's got me thinking about, baby friendly.
Yeah, well, we've done similar points.
Yes, James, yes.
So, the other James.
A few points really. So first of all, my son was admitted to Epsom Peds about 3.5 years ago, and we weren't offered any food. So actually, this is one of the first complaints that I looked at, and I was very happy to see that we'd changed our approach. I think that in terms of the point about the do we get it right the first time when somebody challenges us on something? I think it's a mix, and I think it will always be a mix. I think this is why we have the seniority of complaints sign-off that we have. I mean, generally it's myself or Arlene or Richard who signs them off. And I think that there are times, certainly, when I push back to say, actually, I think we are being too defensive. I think we need to be more open-minded to the issue that somebody's raising with us and need to reconsider our response in that context. And that is why that senior review of ultimately when something does become a formal complaint, it's sort of a last line. You would hope that we've taken the right response earlier, and I do see many teams be very flexible and very responsive, but equally we need to have that senior review to make sure that that is taking place. We actually had a briefing from the lead staff for the Baby Friendly Initiative at our Team Talk Live session this Wednesday, and they talked a lot about the support for both breastfed babies but also for parents and children of bottle-fed babies as well. So it did feel to me, and it might be worth a more structured look at, but it did feel to me that the approach had shifted to being a more equal one, just from the way they were talking to our staff. So I think it's quite helpful that we've had that input this week as well.
Can I just come back on the...
Of course.
Yeah, so as James has said, it's very much, I think at one point people used to perceive that baby friendly was all about breastfeeding, and therefore everybody had to breastfeed, and it really isn't. It's about how we encourage mothers to bond with their babies and dads and significant others and all of that, but skin to skin, and ensuring that parents have the right education around nutrition, not just breastfeeding. So I think when maybe 5 years ago when it was implemented, it was seen as, breastfeeding was the thing to do, and it isn't. Baby friendly is not just about breastfeeding, and more that is being highlighted. It is about ensuring though that, little things like ensuring that we don't get formula manufacturers sponsoring big conferences where they advertise their formula. That's a very different thing.
I think it's about empowering parents and BFI, empowering parents
and
to make informed choices and providing the support. And if a mum has chosen to bottle feed, we absolutely have to show them how to make up feeds correctly. So it's not that we've gone completely the other way and that we just talk about breastfeeding. It is about informed choice and support. And I think, we're very measured in how we do that within the trust, both on the maternity side, neonates, and in paediatrics. No, I mean, I wasn't involved in this, so it was really interesting to hear it, but I think the point about the PALs and the complaints is quite interesting, because a lot of our teams seem a bit afraid to pick up the phone and chat to somebody, you know, and actually you can stop the things in the path, can't you, by doing that. So it's about us supporting as senior nurses, our teams, that they feel they can do that, you know, and also that you can say sorry, yes. Because like you say, people are so defensive, and actually, whether we've been right or wrong, it's how we've made that person feel, isn't it? So I think that's key. But,
yes, you're so right. Sorry is a word that I kind of use quite a lot.
Yeah, there's nothing wrong with it.
It's a pretty good word.
Yeah, actually. And people don't like to. They think it's I'm admitting to some failure if I say sorry, but actually I'm sorry that we made you feel like that, and you know, what can we do to make it better, I think is really important. Yeah.
Final point. A quick, more general point. I mean, in a world of constrained budgets, we are going to be faced with scenarios in which we're not able to respond positively to complaints if they involve additional resources. And in that context, we just also need to be better at explaining why we can't. It's not just because we have a rule or the policy, but there's a serious issue about choices and priorities, and we'd love to do more, but we can't. There are limits.
Well, it's a much broader point that I was discussing, was it with Betty as I was going around this morning, somebody, maybe it was Arlene, that there isn't a proper debate in the country about what can and can't be afforded. And there was an interesting report in the newspaper yesterday that said if we carry on growing the NHS to cope with demand, which is endless, we will be spending 100% of GDP by, I think it is 2085 or something. And you just have to say that to know that at some point there have to be lines drawn, don't there? But to Teresa and Nadine, thank you very much for coming and sharing the story, and thank you for all the flexibility that you showed and responding in the way that you did. I think that's a real role model for the whole organisation. So thank you very much indeed.
Thank you.
Thank you. Bye-bye. So this actually brings us to the end of our meeting. We note that our next meeting is the 4th of November, and now the meeting is closed, we deal with written questions, of which we have a number. And so the first one is from Mr. Keith Francis. I'm going to ask James both to encapsulate the question and answer it. James.
Mr. Francis had a question about how he got the board. He didn't want to pay for parking and then had some specific questions about which buses he should use. I don't think we can respond on the buses because we don't quite know the nature of Mr. Francis's journey. But what we can confirm is that we can arrange free parking for any member of the public who wishes to attend the public board if we're contacted 24 hours before the meeting is due to start. So, and I think that offer is set out on our website. So.
Okay, well, I think it's a very fair offer. Thank you, James. And then we've got a number of questions. I hope I pronounce the name right. It's Mr. Lahendran, and he's the chair of Merton Seniors Forum and the vice chair of Merton. Well, a lot of initials there, not all of which I wholly understand, but anyway. And he's got a number of questions. You're going to take us through, James?
Yes, so Mr. Lahendran's first question is how long he says how long has this consultation been going? What we would say is that we've actually, the consultation around the Improving Healthcare Together scheme was actually concluded. £500 million of funding for the new hospital at Sutton was secured in January 2020 and completed in April of that year with the outcome published in July 2020. We can't release finances on this. It would be a matter for the ICB, and I understand it's also commercially sensitive. But the trust is absolutely focused on getting the best value out of every step of the subsequent process. The next question is whether the hospital plan is still on the drawing board. We have done quite a lot of work on the main parameters of the design for the new hospital. We have now communicated that the completion date has been revised to 2027 at the earliest. We've also communicated that we are working very closely with the new hospital programme, both on the plans to finalise the design of the new hospital and then get to building it, and also the timescale. So we've done substantial work, but there's substantial work still to come. And his final question is, with the merger, it says with GESH, will this hospital ever be built? I think it's important to clarify that we formed a hospital group between Epsom and St Helier and St George's, and this is allowing us to provide even better care more efficiently for our local communities, but the two trusts have not merged. It does not impact the funding for the new hospital, which has been secured, and we continue to await instruction from the new hospitals programme as to the next steps.
Thank you, James. And actually, there's a further question from Mr. Landron, but that's going to be answered by Arlene.
Thank you, Gillian. And this question is around with the formation of GESH, will we be encouraging mothers to have babies at home rather than to go into hospital? And I suppose we start by reinforcing that it's not a merger, that it's the two trusts have gone into a group and remain independent statutory bodies. In terms of maternity services, the fact that we are in a group has no bearing on whether on any drive to encourage mothers to have babies at home, although both organisations do provide services for home births. There will be no extra drive to do that. The maternity services at Epsom and St Helier and indeed at George's have both been visited as part of the Ockenden reviews, and the maternity services here have received really positive feedback. And among that feedback was really a recommendation that we work as a group to provide opportunities for learning across the both organisations, and we will very much be working to do that.
Thank you very much indeed, Arlene. And the final question is from Mr. David Elliman, and this one is for James Marsh. James.
Thank you. So Mr. Elliman is from Healthwatch Sutton. And he's noted that whilst Epsom, St Helier and St George's haven't merged, we are undergoing a lot of collaboration for a number of our clinical services, and he talks about cancer services, but he recognises that there are potential benefits of this closer collaboration. And I think he was asking about assurance that where there is significant service change, will there be appropriate consultation? And he also mentions including a merger of the two trusts. So the response to this is absolutely we agree that one of the core drives of us forming a group between Epsom, St Helier and St George's were to really explore the synergistic benefits of closer working relationships between some of our clinical services, and that work is definitely underway, and there's a lot of mutual learning for some of our services. So we're learning already from each other. Where our services might result in significant service change, absolutely we would fulfill all the usual requirements for public involvement. And a case in point, we heard about the renal services working closely together. And we've undertaken public engagement about potentially integrating the two trusts' renal services, as well as engaging with our clinical senates, commissioners, and health oversight and scrutiny committees.
Lovely, thank you very much indeed, James. So that's the end of our public questions. So thank you to everyone in the audience. Thanks to all members of the board. We've kept time pretty well. Time for some refreshment now. And then I suggest we come back at 1:15 for our next session. That's okay? All right. Thank you, everybody.